continuation of our ISG monthly meeting. This time around we have a new president, Dr. Prem Kumar, taking over for conducting this meeting. Welcome him. I request him to give the welcome address, followed by
for a change, he is giving welcome address.
Welcome. Respected teachers, colleagues, dear postgraduates, at the outset I thank all of you for having elected me as the president of this TNIG chapter. My association with this chapter started way back in 2002. After completion of my BM, Dr. Karlan and I met Dr. K.R.P. sir and Bala sir and volunteered to help in 2003 ISG held in Chennai. Since then my association started. I started as a GC member, became a treasurer, became a secretary and then became a treasurer again. And then now I have become a president again. I'm happy to be associated with this association for a long time. And I've seen this our chapter growing leaps and bounds. It has been we had received the best state chapter award during the last year. It shows the depth and the way our society is functioning. And way back in 2003, when the society was revived, there were only few meetings every month, and then you used to be a lecture, and then over the period, and slowly when PG session was introduced, and new concepts and new novel ideas were introduced into our society. I'm sure that our society has grown leaps and bounds, and then this will continue and it will grow more. And these few words, I thank everybody, and then we'll go ahead with the meeting.
Thank you, sir. We'll start off with our postgraduate session. To chair this session, I request Dr. V.S. Shanti, Senior Consultant at Railway Hospitals, Perambur, Dr. M.A. Aravind, Senior Consultant at Kaveri Hospital, Dr. B.J. Gokul, Senior Consultant at Mid-India Hospital, and Dr. Santosh Anand, Surgical Gastroenterologist from Apollo Hospitals. Over to the chairpersons to conduct the meeting. Thank you.
Presented to us with the chief complaints of abdominal pain for 6 months, vomiting and dark colored stools for 10 days, and breathlessness and exertion for the last 1 week. Coming to the presenting complaints, patient presented to us with the complaints of history of intermittent epigastric abdominal pain for 6 months, which is burning in nature, non-radiating, associated with intermittent episodes of ball rolling movements and postprandial fullness, relieved with vomiting and early satiety. A patient also had, for the last 10 days, non-bilious vomiting, which is 3 to 4 episodes per day, which occurs 1 hour after the food intake, no stale food vomitus or no blood in vomitus. Patient also had dark blood in stools for the 10 days, 2 episodes per day, foul swelling, no giddiness, no syncope or no bleeding per rectum. He also had history of EC fatigability and breathlessness and exertion for the last 1 week, no chest pain, palpitations, orthopnea or no sputum production. And other complaints says history of loss of weight of approximately 5 kg over the last 2 months, no history of awareness of lump or hematemesis. With these presenting complaints he presented to us. With past history, he is a known case of old pulmonary tuberculosis diagnosed 20 years back and took ADT. No clear records were not available. For the above mentioned dyspeptic symptoms, he took PPI therapy over the counter on and off for the last 6 months, after which he didn't have any significant improvement. Personal history, he is a chronic alcohol use disorder for 40 years. He takes 120 gram per day, with the last binge being 1 month back, and chronic smoker with a smoking index of 400. He takes mixed diet, bowel and bladder habits were normal. On examination, patient conscious, vital stable, patient at the admission had severe pallor, no cervical lymphadenopathy seen, BMI of 20.4. On oral cavity examination, he had melanocytic macules over the tongue and there is hypopigmented patch over both the lateral borders of the lips. But this is attributed to smoking. On systemic examination, per-abdomen examination, there is no soft, no visible mass, no organomegaly, no visible gastric peristalsis, bowel sounds present. Per-rectal examination, patient had melanin stools, other system examination were normal. We proceeded with initial investigation, complete blood count. Patient at the time of admission had severe anemia with a HB of 3.7 with a microcytic hypochromic picture. During the course, we transfused multiple blood transfusion and after which HB improved with a 8.7. His peripheral smear showed microcytic hypochromic picture. Renal function and liver function tests were within normal limits. The other investigations like thyroid, HbA1c, viral markers were all negative. In view of dyspnea, we also did 2D echo X-ray which are all normal. We proceeded with initial imaging ultrasound abdomen which was grossly normal. So with the database whatever we have, in history we present a patient with a 63-year male, gastric ulcer type pain for 6 months, recurrent non-bilious vomiting for 10 days, intermittent ball rolling movements which gets relieved with vomiting, early satiety and weight loss. There is history of melena. There is history suggestive of anemia like easy petitability and breathlessness on exertion. There is a past history of PPI use for 6 months and risk factors chronic alcohol use disorder and smoking. On examination, patient is severely pallor, melanocytic macules seen over the tongue with melanic stools are present in per-rectal. Investigation showed microcytic hypochromic anemic picture and normal other investigations. So with this database, we came to a diagnosis of gastric outlet obstruction, likely partial gastric outlet obstruction. So we proceeded with upper GI endoscopy. So this is the upper GI endoscopy which showed from distal esophagus. Now we are entering into the stomach. On entering the stomach, we couldn't find the pylorus opening. So you could see there is a mass-like lesion like intercepting into the pylorus causing obstruction. We did air insufflation. So now with air insufflation, this mass lesion now reduced back to its original location in the fundus of the stomach. Then we proceeded to the D1, D2 which are all normal. On doing fundic maneuver, we could see there is a thick, large pedunculated polyp with a thick stalk, approximately 5 to 4 cm, seen in the fundus of the stomach. So this is the lesion with the head having some bossylated appearance. We took biopsy from the polyp and also from the normal intervening mucosa. Thus, this is the biopsy which is showing there is a polyp with cystically dilated glands and lamina propria showing inflammatory infiltrates. So which are all suggestive of fundic gland polyp. So to rule out other polyps, we proceeded with colonoscopy. Colonoscopy was normal. Then we did one imaging CECT abdomen to look for small bowel also, to look for local site also. We found there is a sharp enhancing lesion seen from arising from greater curvature of stomach and descending into the pylorus causing obstruction. The far plane between the liver and the lesion and the pancreas and the lesion are all preserved and no surrounding lymph nodes and the small bowels are normal. So, like to summarize, we have a 63-year-old male with presented with partial gastric outlet type obstruction feature with endoscopy showing large pedunculated polyp causing GO-like picture. So, considering the large size of the polyp and like we took the surgical gastro opinion and we went through the literature review also and we proceeded with a laparoscopic transgastric polypectomy. So this is the procedure. First, it is endoscopic assisted. First endoscopy was done and position of the stomach is confirmed and through laparoscopy anterior gastrectomy was done and polyp was removed using endoscopy. So this is the patient's polyp, large pedunculated polyp with the head having vacillated appearance arising from the fundus of the stomach. This is the intra-op images. So the intra-op findings are a polypoid lesion of size 5 into 4 cm arising from the fundus of the stomach, intercepting into the pylorus with a thick star. So this post-polypectomy we sent the biopsy. It showed that the right side image it is showing features suggestive of nuclear atypia. There is an irregular scattered nuclei and also there is congested blood vessels in this picture which are all suggestive of adenomatous polyp with low grade dysplasia. In view of adenomatous polyp with low grade dysplasia, we kept under follow and in follow the patient is asymptomatic, his anemia resolved, HB is now 11.2 and we did follow up endoscopy which showed there is no recurrence of the polyp or there is no new polyp in the scene. In this the resected site is seen. So timeline 63-year male presented with ulcer pain with partial gastric outlet picture. On examination, patient had severe pallor. We proceeded with upper GI endoscopy, which showed large pedunculated polyp with causing GOO. Biopsy showed fundy gland polyp. We did colonoscopy also, which was normal. We did on initial imaging CECT abdomen. CECT confirmed the findings of endoscopy. We combining multimodality approach. We took surgical gastro opinion and we proceeded with laparoscopic polypectomy. Post polypectomy, biopsy was suggestive of adenomatous polyp with low grade dysplasia. And we kept under follow. Now the patient is not having no recurrence of polyp, normal endoscopy, and patient is asymptomatic. So coming to the discussion, gastric polyps. Usually gastric polyps are incidence 5%. Most of them are asymptomatic. Usually large polyps present with iron deficiency anemia, bleeding, abdominal pain, or gastric outlet obstruction feature. Only few case reports of gastric polyps causing GOO reported in literature. Even fewer reports and adenomatous polyp originating from the fundus as in our present case. So like we know there is various types of polyp. The commonest to being like a fundy gland polyp, hyperplastic, and next is adenomatous polyp. Fundy gland polyp, sporadic or familial is there. So this is the British Society of Gastroenterology guidelines, like where gastric polyp, whenever you detect incidentally on imaging, first document the size, number, location of the polyp and assess for the chronic atrophic gastritis changes, look for H. pylori and neoplastic changes and go for biopsy. If biopsy is suggestive of fundic glandular polyp, if fundic glandular polyp with no atypical features less than 1 cm, no need of follow-up as they have very low malignant potential. If fundic gland polyp more than 20, we are likely dealing with some polyposis syndrome, evaluate in that case. Fundic glandular polyp with atypical location like antrum, dysplastic changes are more than 1 cm, go for resection. Or else we can either land up with hyperplastic polyp. If hyperplastic polyp, always remember hyperplastic polyp strong association with H. pylori, so go for H. pylori eradication. If H. pylori, after H. pylori eradication, if still there is more than 1 cm polyp, pedunculated or more symptomatic, go for resection. And or else like any adenomatous polyp, you have to resect at any cost. And post resection, like any patients in this post polypectomy, features suggestive of dysplasia, you keep under annual follow-up. So in this case, we landed up in adenomatous polyp with low grade dysplasia. We kept under our follow-up, which was now there is no recurrence. So coming to the review of gastric polyps leading to gastric outlet obstruction, the median size of polyp removed endoscopically it was 3 cm. But till now, only one study from Kumar et al. In the year 1996, the largest polyp removed endoscopically was 8 cm. But it is a 2-stage procedure, not a single-stage procedure. but the median size of surgically removed polyp was 6 centimeter. So in our case 5.4 into 4 centimeter, so it is wise to go for surgical resection. So this is the review of another review where the polyp, gastric polyp arising from the fundus causing GOO. Usually whatever the case reports we went through, we have like majority of polyps were antral polyps causing GOO, but only 4 or 5 cases till now from polyps arising from the fundus causing GOO. In that cases, like most of them, we proceeded with laparoscopic surgical resection as in our present case. And like we also went through all the case reports and we divided like all the polyps who underwent endoscopic polypectomy, who underwent surgical resection. As I already mentioned, the median size underwent endoscopic polypectomy was 3 cm. Only one 8 cm by Kumar et al., which is a 2-stage procedure where the adenomatous polyp arising from the antrum. Surgical resection, majority like more than 5 cm as in our present case. So like hereby I thank our Department of Surgical Gastroenterology, Stanley Medical College for helping out. Thank you.
Perforated polyp, we can try snaring it up.
Sir, but sir, we can snare it, sir, but the size of the lesion is too large. Like we can go only piecemeal resection in such cases, sir.
Perforated.
Yes, sir. But it is if there is a large size, there is a risk of like malignant potential also very high. So considering entire picture, we proceeded with the laparoscopic resection, sir.
It's a nice. So my comment is usually fundic polyp are multiple. Usually occurs as a consequence of long-standing PPI usage. So initially when you go the biopsies fundic polyp,
Yes, sir.
we thought it was possibly benign and we would have attempted an endoscopic resection by application of endoloop.
Yes, sir.
So later it came as a surprise that it is an adenomatous polyp and not fundic polyp.
So, like initially we do thought like endoscopic resection, but considering the large size of the polyp and through the literature, like never like median size more than 3 centimeter. The risk like either you can go for a 2-stage procedure. Also we are not convinced with the fundy gland polyp. Like median PPA use minimum more than 1 year to cause a fundy gland polyp. Approximately as per the case reports or everything, it is given 5 years of PPA use to cause fundy gland polyp. In this case, it is only 6 months. And entire clinical picture, we are not convinced with fundy gland polyp. Also, we took only forceps biopsy. Forceps biopsy can misdiagnose, underdiagnose in nearly 10 to 25% of the cases. So we are not convinced, so we went with surgical resection.
Here is endoscopy, if you want to resect also the size of the snare.
Size of the snare is
Something big enough for 5 centimeters.
That's one thing. When we inject some adrenaline into the stalk, the polyps, such polyps can shrink. And a 5.5 centimeters can be could have been used. Though it is risky, as you said, bleeding is a possibility.
Once you clip the pedicle, blood supply comes down. The size of the polyp on the head also comes down. That's how it should be done.
It was presented very well. So very presented was very good. Thank you very much. Thank you, Dr. Krishna Kumar. We then move on to second case of today evening. This is from Apollo Hospital Medical History Department by Dr. Kiran, and he is going to talk about an interesting case or a cause of ascending cholangitis. Over to you, Dr. Kiran.
Good evening, everyone. My name is Dr. Kiran, academic register first year from Apollo Mains Hospital, and welcome to my case presentation. Here I present a case of 30-year-old male who is coming from Assam. He is a meat handler by occupation with the chief complaints of pain in right hypochondria for the past 2 years. On elaborating his presenting complaints, this pain in abdomen started in an insidious onset of moderate intensity, dull type, with no radiation and no association with food intake, and it was persistent. Recently, the pain has increased in intensity for the past 1 week, and it increases about an hour after the food intake. Along with this, there was associated yellowish discoloration of eyes, dark colored urine, and pale colored stool for the past 1 week. And also complaints of fatigue and fever with rigors on and off for the past 1 week. No other significant past history. His past history, no other significant presenting history and no other significant past history. His personal history, he is a consumer of mixed diet. His alcohol and pan user on an occasional basis. His family history was not significant. On general examination, he was conscious, coherent, well-built, well-nourished. His positive findings of ictus were present. He had ECOG performance status of 1. And he was hemodynamically stable, and there are no signs of liver cell failure. On abdominal examination, the inspection was unremarkable. On palpation, he had a right hypochondrial tenderness with no organomegaly or guarding or rigidity. Percussion and auscultation was unremarkable. Other system examinations was within the normal limits. Now moving on to the investigations. So this is the complete blood count. In this, there is no anemia, and we see a leukocytosis with a increased percentage of eosinophils of 32%. So this is the LFT, which is shows a pattern of cholestatic hepatitis with a raised total bilirubin, mild elevation of transaminases, and a GTTP and ALP elevation. Proceeding on to the other investigation, his RFT was normal, his viral markers were negative, his INR was normal, and electrolytes were normal. Moving on to the next imaging, the imaging ultrasound which he did in Assam. We see a cyst-like lesion with a multiple septate within. So this is the official report of that ultrasound. It's a large cystic lesion in segment 5 of liver of 17 into 59 millimeter, multiple large cysts within, probably a hydrated cyst. Now we moved on to take an X-ray to see whether he had any cystic lesion in the lung, and there was no obvious abnormality in chest X-ray. Now next we moved on to doing a MRI abdomen, MRCP. Here is the video. So this is the T2 sequence, and we can see a cyst-like lesion with multiple septate within in segment 6 of the liver. Next we will be going to the MRCP sequence. So okay, in this MRCP sequence, you can appreciate there is a distal smooth narrowing of the distal CBD with the upstream dilatation of the CBD, and we are again seeing the cystic lesion with what seems like a biliary radical communicating with the cyst. So this is the best snapshot image I took. So you can see this smooth narrowing of the distal CBD with upstream dilatation of the CBD and intrahepatic biliary radicals, and possibly a biliary radical communicating with the cystic lesion. But this is the official report, which states well-defined thick-walled partial exophatic cystic lesion with multiple septate hyphae in segment 6 of liver, suggestive hydrated cyst, but there was no evidence of direct cystobiliary connection was noted, and carbohydrate disturbance sludge, and as I mentioned, CBD was dilated with a maximum caliber of 8.5 millimeter, and they told that it could be possibly a distal benign biliary stricture. So next, our working diagnosis was hydrated cyst of liver with biliary communication, and we asked this obstructive jaundice, which is the acidic cholangitis developed in this setting. We thought that there was a possibility of a contents from hydrated cyst which moved to the distal CBD obstructing it. We took a consult from the infectious disease consultant, and we started him on albendazole for 1 week, and we discussed this case with the hepatobiliary surgeon, And from both our side, we felt that there was a need for biliary decompression before proceeding to other management, and it was followed by a therapeutic ERCP. So this is the ERCP video. So after sphincterotomy, we can see a clear fluid coming, draining out, and after this, you will just see right now. Okay, you can see some ice apple like bits or mucoid things in the fluid. So CBD was standard, biliary sphincterotomy was done. Clearby along with ice apple like bits we are seen. So the next thing is we try to negotiate the guider into the biliary system, into the biliary radicle, into the cyst, and we could see the guider looped within the cyst. So we demonstrated that there is a connection between the biliary radicle, the biliary system, with the hydatid system. So this is the image. So you can see this guider going this from biliary radicle and it's the looping within the system. Move on to next one. So at that time again we sent the serology reports. It came for echinococcus antibodies IgS positive. Bioculture showed Klebsiella pneumoniae Pseudomonas bifida. Next we went with the hepatobiliary surgeon and the surgery was performed laparoscopically. So the intra-op findings were there was a smooth wall hydatid cyst of size 6 cross 4 cross 4 centimeter in segment 6 of the liver with a small communication to the minor bile duct from the biliary as well. Confirming our ERCP findings, and gallbladder was distended sludge. So in the procedure wise, the cyst was dissected from the surrounding liver, cystobiliary communication was clipped and divided, and the cyst was excised in toto. The gallbladder was also dissected from the liver bed. Both of them were retrieved to the endobag from the epigastric ward. After this surgery, the patient recovered post-operatively without any events, and he was discharged, and he was told to continue albendazole. So these are the literatures which I found in it. So this was a study done in Chile, which was published in Annals of Hepatology in 2016. So this study was mainly a 10-year study period where they included the spectrum of cholangiohydatidosis, and the main aim was to find out the post-operative morbidity of this spectrum of disease, which they found to be a little bit higher. So this was a case presentation done in RMLG. This is similar case. 41-year-old male presenting with hydatid cyst with cystobiliary communication and with ascending cholangitis. Like us, they also did a therapeutic ERC for decompression and he was proceeded. So the RMLG is some Italian name. So next thing. So this journal was this was published in American Journal of Surgery. So in this they studied about the role of ERCP for intrabiliary rupture hydatid cyst, and what their conclusion was, patients who underwent before surgery who underwent a therapeutic ERCP had better outcomes compared to those people who didn't underwent this. So take home messages. So rupture of hydatid cyst in the biliary system is an anti-vasovator complication hydatid cyst, but ascending cholangitis due to this is rare with few case reports. ERCP can be done in this patient for biliary decompression, which is relatively safe, and it has a better clinical outcome without going straight for surgery. Thank you.
What is the cause of dilated CBD? Is it an extraneous compression, or do you think there is a stricture? Because you said it is stricture.
Those pictures are only that material was there.
The material of
Plenty of hydrated material blocking to your website. Yeah, for the edema, the MRCP simulated the stricture, but what's needed is to make the
Did he have fever?
yes, sir. Before Prasanicus, he had fever on and off, chills and fevers.
Doctor, you said specifically in the history,
Yes, sir.
meat handler.
Yes, sir.
Was there any importance to that?
Yes, sir.
Professionally, he was a meat handler.
Yes, sir. A
He
problem.
gave other parasites.
No, I'm just asking, is meat handling hydatid any relation?
The main source is from dogs, but yes, sir, I think it's relevant totally.
In what way it's relevant?
Sir?
In what way it's relevant? If he's a meat handler,
Yes.
he will not get hydatid. If he throws the remnants of the meat into the road, the dog will eat that. So he can cause problems to the community. Understand?
Thank you.
So what it says is, man is a intermediate host. Definitely host is dog. 24 years back, when I was in with G.V. Rao and Nageshwar Reddy, at that they were doing the work at Medinoma Hospital. I happened to see a case of dialysis with biliary communication and similar picture of dilated CBD and IHBR dilatation. They did ERCP, spectrotomy. They have retrieved even the daughter cysts. Daughter cyst was retrieved and they went up to the extent of entering into the head cyst of the segment 5. From there also they retrieved. Then they put 2 stents. 24 years back.
That's called the Camelot sign, sir. The moment you Camelot sign.
Yeah.
Once you decompress, the cyst size comes down to present.
So I was surprised that our job was done by through endoscopic technique. It was a big surprise.
No, but it did say they are leaving the cyst there. So the recurrence of infection can still.
Yeah, that's correct.
Temporary measure, it's okay.
Yeah, that's correct.
Not a permanent.
Yeah, you're correct. That is, provided see, there are 3 layers of cyst. Ectocyst, endocyst, and another. The 2 inner cysts are more, contagious. That they produce the daughter cysts. The one, the periphery is a fibrosis with that is of course. So that's why you should do actually cystocystectomy for a definitive cure actually if you have to do it.
I have just one thing. Was it required to enter the cyst? Was it required to enter the cyst through the guide wire?
No. We wanted to stent only the main CBD because the MRCP said no biliary communication, and we happened to have a very experienced assistant who manipulated the guide wire into the biliary.
That could cause complication. That's all I wanted.
The anesthetist warned the patient and the family that in case of any anaphylaxis, he will be going to stay. He was intubated to be on the safe side. But I think within the biliary contact, anaphylaxis is very less. If the wire punctures a blood vessel and then touches the cyst. But we used a dermo on this.
Did the surgeon leave a drainage tube there after the surgery?
Sir?
Did the surgeon left a DT, drainage tube, after doing the procedure?
No, sir.
You could not answer.
No, sir, no.
See, most of the cystobiliary communications, the bile leak will be after some time, not immediately. It will be after 3 to 4, 5 days. Because what happens in the intrabiliary pressure, when the cyst is intact, the cyst pressure is higher than the intrabiliary. Once the cyst is decompressed, the higher intrabiliary pressure, the bile leaks into that. It comes. I have seen one of my patients who has bile leak on the 5th day. I discharged him, he came back. Fortunately, he gave this thing. So
They identified. They
then, but still, you cannot take a chance.
Thank you, sir.
How long will you continue albendazole following surgery?
It's for 3 months.
Okay?
That point for postgraduates. You start 1 week beforehand and continue for 3 months. This is a very active cyst, no? Daughter cyst is a growing cyst. It's not a calcified dead cyst.
You could have shown the laparoscopic video. And the surgical part was very
Agree, Shankar.
very unglamorous.
Agree, Shankar.
Thank you, sir. Thank you, sir. Thank you for your time.
Thank you, Kiran, for the presentation. For the next case, can I call upon Dr. Vidima to present a case of mesalamine tablets taking a better?
Good evening, everybody. I am Dr. Ridhima Dubashi. My topic for today's case presentation is mesalamine tablets taking a detour. A 61-year-old male presented to our OPD with chief complaints of hematuria and dysuria since 3 days. He was vitally stable. On general examination, he had pallor. Per abdomen was soft. There was mild tenderness in the hypogastric region. A palpable ill-defined tender mass of approximately 10 into 10 into 8 centimeters was present in the hypogastric region. On admission, his hemoglobin was 6.9. WBC count was 14,500. He came with an outside USG abdomen suggestive of diffuse thickening of the bladder wall with multiple calculi with suspicious discontinuity in the dome of the urinary bladder. A suspicious collection of 6.5 into 6.2 centimeters in the supravesical region was present, communicating with the urinary bladder. We did a CCT abdomen which showed a loculated well-defined fluid collection of 8.8 into 12.8 into 8 centimeters with particulate matter, air pockets and large enteroliths in the pelvic region in midline. Pelvic small bowel loops, that is distal jejunal and proximal ileal loops, were adherent to the collection. The fistulous communication of 1.5 into 1.3 centimeters was noted between the lower aspect of the collection and the urinary bladder with multiple enteroliths in the bladder. Multiple mesenteric and retroperitoneal enlarged lymph nodes were noted. So this is the CCT abdomen of the patient, which is showing an abscess in the midline with multiple air foci present within it with jejunal loops and pelvic loops adherent to it. This is the abscess, this is the air foci, these are the jejunal loops adherent to the abscess. These are suspected enteroliths in the urinary bladder. So past history of the patient is as follows. 6 months before he presented to us, in the month of May 23, he had generalized weakness and fatigability. He was diagnosed to have dimorphic anemia and was given IV ferrous carboxymaltose. UGI done at that time showed H. pylori positive gastritis and 2 duodenal ulcers, for which he was started on HPE kit. CCT abdomen revealed mild thickening, edema of the jejunal loops with prominent valvular convergence and mild mesenteric fat standing with final impression suggestive of mild jejunitis. This is the CT scan of the patient done that time, which is showing thickening of non-specific mild thickening of the jejunal loops with features suggestive of mild jejunitis. 3 months later, in the month of August 23, he was readmitted at that outside hospital with significant weight loss. Investigations revealed iron deficiency anemia, for which treatment was instituted. 2 units of PRBC transfusion was given and 1 unit of iron was transfused. Repeat UGI scopy revealed healed duodenal ulcers. CT enterography and CCT abdomen showed mild wall thickening of the jejunum with few hyperenhancing foci of 3 into 10 millimeters in the jejunum. Mesenteric lymphadenopathy of 13 into 9 millimeters was noted in the left hypochondriac and left lumbar regions. Fecal calprotectin was 237 micrograms per deciliter. Single balloon enteroscopy showed multiple erosions and aphthous ulcers in the jejunum, and biopsy of the jejunum showed a few lymphoplasmacytic infiltrates. Biopsy did not show any signs of malignancy or did not show any granulomatous lesions. A diagnosis of Crohn's disease was made empirically outside and he was started on tablet mesalamine. This is the CT scan of the patient, which is showing an increase in the thickening of the jejunum compared to the previous scan. These are the prominent jejunal loops which have been thickened compared to previous CT scan. Colonoscopy done at that time did not reveal any findings, it was normal. So to recapitulate, this was the past history of the patient. He presented to us with hematuria and dysuria for 3 days. This is the present CT scan of the patient, showing a pelvic abscess with air foci with jejunal loops adherent to the collection and suspicious enteroliths in the urinary bladder. We decided to go ahead and post the patient for surgery. Preoperatively, 1 unit of PRBC was transfused and patient was taken up for surgery. Exploratory laparotomy was done. A fistulous communication between the jejunal loops and dome of the urinary bladder was noted. The enterovesical fistula, along with the mass and affected segment of the jejunum, was excised. What was reported to be enteroliths were actually intact mesalamine tablets. So 11 mesalamine tablets were retrieved from the urinary bladder. Primary jejunal anastomosis was done along with repair of the urinary bladder and placement of a suprapubic catheter was done. So this is the inflammatory phlegmon, which you can see, along with the enterovesical fistula and jejunal loops adherent to it. This was the total specimen that we excised. These are the bowel loops which are adherent to the phlegmon, along with the abscess and the full inflammatory collection that we excised and a part of the dome of the bladder. These were 11 intact mesalamine tablets which we retrieved from the urinary bladder. So the histological diagnosis of the patient came as a surprise. So I request anyone to guess the diagnosis. Histopathology revealed a jejunal lymphoma, a diffuse large B-cell lymphoma of the jejunum. Chemotherapy was initiated 3 weeks following surgery, and post-operative follow-up of the patient has been uneventful till date. These are the IHC markers of the patient. CD20 and CD45 are positive, suggestive of a large B-cell lymphoma. CD10 is negative, MUM1 is positive, suggestive of activated type of DLBCL, and BCL6 also is weakly positive. So discussion, gastrointestinal lymphomas account for 1 to 10% of all GI malignancies and up to 20% of all small bowel cancers. Stomach is the most common site of GI lymphomas, followed by the small intestine. Within the small intestine, ileum is most commonly affected, followed by the duodenum and jejunum. Cases of lymphoma mimicking Crohn's disease have been reported in literature. This is a rare case report of a case misdiagnosed as Crohn's disease with spontaneous perforation of the lymphoma lesion with a fistulous communication with the urinary bladder without initiation of chemotherapy. Enterovesical fistula formation is a rare complication. It is observed secondary to malignancies, trauma, radiation, and inflammatory bowel disease. The morbidity associated with this condition significantly affects one's quality of life. DLBCL is a neoplasm of large transformed B cells that mimic immunoblasts with a significant proliferation fraction of 40 to 90%, with 40% of cases presenting at extranodal sites. Jejunum, as compared to ileum, has less lymphoid tissue and is a rare site of occurrence for primary DLBCL. A review of all GI lymphomas has reported perforation in 9% of the cases, 55% of which occurred after chemotherapy. The presenting features are often non-specific, which pose a diagnostic dilemma. Our case had presented initially with only hematuria, dysuria, and weight loss. Investigations pointed out towards anemia and H. pylori-induced gastritis. Initial CT imaging findings had led then the treating clinician to an initial diagnosis of Crohn's disease. The process of fistula formation is a chronic one, with the lesions gradually invading the serosa and perforating into the mesentery, with confined abscesses or fistulous communications with adjacent organs. Several cases of DLBCL of the jejunum often have had a delayed presentation with complications. Multiple skip lesions on imaging, along with features of bowel perforation, can subject the case to emergency laparotomy, wherein the diagnosis of DLBCL can be arrived at only after histopathological examination. Abdominal tomography is a reliable tool for diagnosis of enterovesical fistula. Primary resection anastomosis of the affected bowel segment with primary repair of urinary bladder is the treatment. So to conclude, intestinal lymphomas can closely mimic Crohn's disease. Primary jejunal extranodal lymphomas are a rare occurrence with non-specific presentations leading to a delayed diagnosis. Chemotherapy-naive lymphoma perforations are very rare, and lymphomas forming enterovesical fistulas are even rarer. Probably initially when the patient had non-specific lymphadenopathy in the month of August, a PET CT scan could have been done because he had multiple lymph nodes. So that time a diagnosis of lymphoma could have come. These are my references. Thank you.
Urinary hematuria, how did he plan a gastroenterology part? That's one. Number two, what about they did an endoscopy, they did a biopsy. What is that biopsy?
Biopsy report showed no features of malignancy with no granuloma, with mild lymphoepithelial infiltrates.
So what is your comment about that? The second answer on the side, they have done a biopsy.
Probably a deeper biopsy or a well biopsy probably.
Extensive biopsies, multiple biopsies would be done. It would have given us the answer there. Right?
Your word of deep tour of mesothelioma. What do you mean by deep tour?
The bladders, into the bladder, into the bladders. Via the from the jejunum into the intravesical fistula, and we retrieved it from the
It's
urinary
taken a
bladder.
long route, but it's not a long route, it is short route. Because small bowel and urinary bladder are almost close. I'm thinking long only, not fast.
Not answered my question. How did he land up in gastroenterology department?
The emergency department. In the ER, sir, he came with hematuria and mild tenderness.
He was
No, sir, no, sir. Tenderness in the hypogastric region.
Hypogastric.
So to answer the question, the patient came with a CT scan done outside. The report was a large pelvic abscess, which is primarily communicating with the bowel because there are air pockets, and it is also making a communication with the bladder. So because of that, surgeon entered.
How did it land up in gastroenterology department?
It was specifically since they saw the jejunal loops, everything. They referred. Actually, it is interesting to note that this patient is a doctor. He himself is a doctor, and he's from an ex-serviceman also. So right now he's on chemotherapy and he's doing well. But initially the CT reported as enteroliths, but these enteroliths are having a very uniform shape. It was resembling like a tablet. So when we opened the abdomen, when we resected the thing, the bladder got open, and we are able to retrieve intact mesalamine tablets. I always doubted the so-called entry-coated tablets. It gets actively released in the ileum or colon. But this is a proof that these are really entry-coated tablets, because this was a jejunal communication. Actually, my plan was to do a resection because of the pus. I thought I will not do a primary anastomosis. We have taken a consent for a stoma, but unfortunately the lesion was in the jejunum. So trying to do a stoma in the jejunum will be a very miserable experience to manage the post-operative output. So we took a chance and we did a primary anastomosis, and luckily it didn't leak.
How long he has been taking mesalamine?
He was taking mesalamine for a couple of months.
They were diagnosed as Crohn's.
Yeah, after doing an
How do you
enteroscopy.
explain that the calprotectin was quite high?
Not high.
1,000.
200. So, I think basically they saw jejunal thickening, unexplained anemia, unexplained weight loss, and they made an attempt to do an enteroscopy and took a biopsy, but biopsy was reported as not, it was conclusive on grounds.
Having Crohn's in mind, how bold were you to dissect the specimen?
I mean, because it has made a communication to the bladder, so there is no way of running
You
away.
have to do it, there's
Yeah,
no
we
other
have to.
go. But you're really bold stuff because it will be recur in another place which is Crohn's.
That's true, sir, but there is no other way to.
Surprised it has turned to be
Actually, this is the second case of, in my experience, where original diagnosis was IBD, coming as a lymphoma. Previously, we had one more case where there are multiple lesions in the colon. 3 colonoscopies have done, and all of them have reported as non-specific. They started on some drugs, and patient came with a cecal perforation one day, and we have to do an emergency subtotal colectomy. Final report came as lymphoma. So this is the second case. I think gastroenterologist should share your experience regarding.
At this era, when everybody is experiencing right and left metronidazole and all anti-emetic therapy, including surgeons who give for anaerobic therapy as intravenous. One patient I did a colonoscopy about 15 years back. Did a colonoscopy, I found multiple large ulcers for the entire colon. I thought it was probably Crohn's with intermittent normal mucosa. Biopsy case came as amebiasis. rare things do occur. It occurs, it comes to a specialist like you, you have to think of rare things.
Okay, sir.
Predisposing conditions for GI lymphoma in this patient, like immunodeficiency states, long-standing diarrhea, which can indicate
Nothing else.
sepsis.
He was diagnosed as trans 3 months ago, started on mesalamine, but no H. pylori could be one of the risk factors, but no immunodeficient conditions.
One question, what is the ESR like? I'm world timer. What is an ESR like in this case? You have not done the ESR? If you have done the ESR, it would have gone above 100. ESR and CRP, these are skyrocketed. Right? No, it is still a standard marker.
All ESR is now become CRP. So now everybody is doing CRP, but still I feel without ERP, without ESR I never see it.
At this admission we didn't do so because he came with a
Always implementing markers should be done. CRP.
No, just not to demean your documents. You have done a wonderful presentation.
Thank you.
Dr. Ridhima, it was a nice presentation. The detour was fantastic. And next we'll be calling Dr. Sanup Kumar Sharin Sabu for review of Indian literature with regard to cholangiocarcinoma. And Dr. R. Vinod Kumar, Senior Consultant, Department of Medical Gastroenterology, GEM Hospitals, the guide for the aforesaid literature.
Good evening all. I will be presenting the Indian Journal Review on cholangiocarcinoma under the guidance of my guide Dr. Vinod sir and Umashanga sir. I am first year DNP PG in German Institute of Gastro. Regarding cholangiocarcinoma is a malignancy of biliary epithelium and it is the most common malignancy of biliary tract. And it is the second most common malignancy in after the hepatocellular carcinoma. So regarding the studies per se, one of the largest study which is available in the literature from India is from Tata Memorial Hospital in Bombay, which had more than 600 patients. It is one of the reported epidemiological largest study in which the age and gender was male predominated and the age was more than 58 years was median age. And a similar study conducted in the same hospital after a year in another department also had similar outcomes with male more than that of females and median age more than 45 years. Regarding the classification of cholangiocarcinoma, which is very commonly known, and this is the MRCP projection image showing the images regarding this is the common bile duct and the common hepatic duct, cystic duct opening, right and the left hepatic duct, and the right and left hepatic duct is being, the left hepatic duct is drained by the segment 2 and segment 3, and the left, in the right side it is anterior segmental duct and the posterior segmental duct. This is important regarding the primary confluence and the secondary confluence. This is a well-known fact where we divide the cholangiocarcinoma into intrahepatic and extrahepatic cholangiocarcinoma, where the extrahepatic cholangiocarcinoma starts beyond the secondary confluence till the cystic duct, till the opening of the common bile duct, in which the perihilar cholangiocarcinoma is still the cystic duct. Why is it important is regarding the common site of occurrence. So with few citation to the epidemiological studies conducted, in the largest study conducted in Tata Memorial, perihilar cholangiocarcinoma was most common, while in Kerala, in South Indian study conducted in Ahmedabad Institute of Medical Science, there too perihilar cholangiocarcinoma was common, followed by distal cholangiocarcinoma. In another study conducted in Kolkata Government Medical College, that was a small study, in that distal cholangiocarcinoma was found to be more than that of perihilar cholangiocarcinoma, maybe because the number of sample size is small, it would have been biased. Regarding the perihilar cholangiocarcinoma, the Bismuth classification, in which type 4 is most common type of perihyalite cholangiocarcinoma, which is cited from the Kerala study from Amada Institute. And regarding the pathology of cholangiocarcinoma, as it's a well-known fact, the pathology, the microscopic appearance of cholangiocarcinoma, it is usually a paucicellular. Many a time we end up with without getting a sample in many suspected cholangiocarcinoma cases. Of the histology, most common histology in the studies is adenocarcinoma, and there are other histological variants like Isgtnc and adenosquamous and squamous and small cell also. So this is the study in Kerala, one of the epidemiological study, where we see that adenocarcinoma still remains the most common and well differentiated was there in most of the cases. So regarding the macroscopically the intrahepatic cholangiocarcinoma can be mostly mass forming type, and the perihilar cholangiocarcinoma can be nodular variant, periductal variant or intraductal. So this is a study conducted in Chennai in Royal Institute of Medical Science by Dr. Mughal and et al., where they found that this was a large study on cholangiocarcinoma, where they have found that the most common variant in intrahepatic cholangiocarcinoma was the tubular or Asnar variant of adenocarcinoma, and mass forming adenocarcinoma was the most common variant. And this is something very interesting, that is in the same study by Dr. Mughal and et al., they showed that there are some lesions known as precursor lesions of cholangiocarcinoma. Though premalignant lesions of intrahepatic cholangiocarcinoma is rare, they have documented few of the precursor lesions like the hepatic adenofibroma, biliary hematoma, bile duct adenomas, biliary intraepithelial neoplasm with low-grade dysplasia, and intraductal tubular-papillary neoplasm. Why is it important? Many times this biliary intraductal neoplasia with low-grade dysplasia, even the pathologists used to tell, they will not be confidently telling that it is low-grade dysplasia, it will not transform to malignancy or cholangiocarcinoma, because in cholangiocarcinoma often wonders may happen. Even though they show it as low-grade dysplasia, they may turn into a intrahepatic cholangiocarcinoma itself. So regarding the clinical features, most studies they agree to the fact that abdominal pain is the common feature in case of intrahepatic cholangiocarcinoma, and in case of perihilar and distal cholangiocarcinoma, often as known, obstructive jaundice was found to be the most common feature. This is from the largest study from the Tata Memorial, that epidemiological study with more than 600 patients showed that in total, it was the pain was the most common feature, but in intrahepatic cholangiocarcinoma, also pain, while in case of perihilar cholangiocarcinoma, it was 59.6% had jaundice as the most common clinical feature. So other studies also, when we take, there is a study from Madras Medical College from the Department of Oncology, where they took the cases of advanced cholangiocarcinoma. In that study, jaundice was found as the most common clinical feature. Maybe because that was a study with advanced cholangiocarcinoma, so they ended up with, most patients ended up with jaundice. While another study in Amada Institute of Medical Science also, jaundice was the most common feature. In Kolkata study in Kolkata Medical College, jaundice was the most common clinical feature. There are also some rare case scenarios of cholangiocarcinoma. It is not that always they present only with pain and jaundice. There are reports of rare cases where cholangiocarcinoma has been misdiagnosed as liver abscess in Gangaram Hospital, or Budd-Chiari syndrome presenting as intrahepatic cholangiocarcinoma, Leng-Mets, cavitating Leng-Mets presenting as intrahepatic cholangiocarcinoma in Delhi, then ataxia telangiectasia with combination of IHCC, HCC. The importance is chemotherapy and radiotherapy should be adjusted in patients with ataxia telangiectasia. The intrahepatic cholangiocarcinoma in the background of biliary adenofibroma in Tata, Bombay, it was reported. So these are regarding that, those rare cases. This is about the intrahepatic cholangiocarcinoma which masqueraded as a liver abscess. So this is ataxia telangiectasia with IHCC, HCC, and this is about the cavitating Leng lesion. And this is Budd-Chiari syndrome, which presented as Budd-Chiari syndrome as a presentation of intrahepatic cholangiocarcinoma, because we know like HCC can come, but IHCC was a rare manifestation. So regarding the investigations to diagnose cholangiocarcinoma, taking to the lab investigations, in the largest, in the Amada Institute study, they showed that bilirubin was almost always elevated more than 8.4 in these groups. Then in intrahepatic cholangiocarcinoma, perihilar and distal, they had more amount of bilirubin levels. So this is one important and interesting study which is published in AIDS in 2007-9 time. So the importance of this study is that they took all cases with, few cases with malignant CBD obstruction, CBD obstruction who present with obstructive jaundice, and so which is malignant and which is benign. So what they have found out in this study is that bilirubin levels more than 8.4. So they compare three factors. One is the total bilirubin level, second is the ALP, third is the CA99. With a cutoff of bilirubin 8.4, ALP of 478 and CA99 100. So what they could conclude in this ROC curve study in AIDS that bilirubin level more than 8.4 and ALP more than 478 were almost always suggestive of malignant causes for obstructive jaundice. So regarding CA99, the sensitivity and specificity as per Indian studies with a cutoff of 37 is 80 and 66. And in another larger study with more than 900 participants in India itself, it showed that sensitivity and specificity was 70 and 78. So in Gujarat, one of the study in Gujarat, they saw that CA99 level, pre-operative CA99 level, when it is 37 to 200, the median survival of the patient was only about 23 months. And when the CA99 level is more than 200, the median survival again comes down to 10.25. And in a study in Bombay with 760 patients, this is a Tata Memorial study, the largest study which I told, epidemiological study. The mean CA99 level was found to be 195. So added on to CA99, it can also be elevated in other non-malignant lesions like bacterial cholangitis, cholelocolidiasis, and other malignancies of GIT. In few patients in the community who has malignancy may also do not present with CA99 due to the absence of Lewy body antigen. This all has Indian citations. So regarding combination of CA99 and serum bilirubin in obstructive jaundice. So this study, what they showed that they took 900 patients who presented with obstructive jaundice, took a combination of CA99 and bilirubin levels, and what they found is that the combination in this 648 were malignant cases. Of the malignant cases, 148 were cholangiocarcinoma. This is study conducted in Topiwala Medical College. So what they found out that a combination of bilirubin plus CA99 had a specificity, increase in specificity and sensitivity to 87.9 and 91.3. Regarding AFP, AFP is a marker of HCC, while in IHCC also sometimes AFP can be elevated. So the reason cited in Indian studies is that some of the cases of IHCC and HCC, they have common stem cell origin and they can too. Some of the IHCC cases can also have raised AFP. Role of IgG4. The role of IgG4 is almost very much important pre-operatively. Many times we will not get a tissue diagnosis for cholangiocarcinoma and we will be end up in a situation where we will have to operate. So what study tells is that before operating the case, please do a IgG4 level to make sure that the obstruction is not an autoimmune cholangitis. Regarding the radiological investigation of cholangiocarcinoma, this is Dr. Chandrasekhar et al. So regarding intrahepatic cholangiocarcinoma, the classical triple phase CT is used, where we can divide three important intrahepatic lesions, that is intrahepatic cholangiocarcinoma, HCC and lymphoma. So as we all know in the triple phase CT, the arterial enhancement in without a washout in the portovenous and the delayed phase is HCC, while in IHCC the most important factor is the rim enhancement. And in primary hepatic lymphoma, there is subtle or no enhancement. Coming to the PET finding, we see that HCC and IHCC, they are usually hypometabolic. While lymphomas, we all know it is usually they are hypermetabolic lesions. So coming to perihilar cholangiocarcinoma, radiological investigation is always choice is MRCP and MRI. Why Dr. Madhusudan et al. In AIMS study. So regarding the distal cholangiocarcinoma imaging, MRCP, when we do MRCP, it is found that many times we end up in these terminologies which comes in the MRCP report regarding obstructive jaundice distal suture. So in this study in India, it showed that abrupt cutoff was not significant enough to differentiate between benign and malignant lesion, while the mass, the irregular margins, asymmetry, increased length of the sutures, they were the features in MRCP which were more suggestive of a distal cholangiocarcinoma when differentiating between benign versus malignant obstructive sutures. So regarding the importance of PET in cholangiocarcinoma, take it from me, the journals tells that PET do not have a role in cholangiocarcinoma. many a times PET can be negative. The role of PET in cholangiocarcinoma are in few conditions like nodular or mass-forming cholangiocarcinoma, intrahepatic cholangiocarcinoma, or if you want to evaluate for Mets of the patients. So this was a large study conducted in Gujarat in Cancer Institute in Ahmedabad, where the reason is that GLUT2-1 expression is needed for PET uptake of FDG glucose. So many times the biliary tract will not have the GLUT2-1 uptake. Only those cholangiocarcinoma patients who have this GLUT1 receptors will show the PET uptake. Regarding the EUS, so EUS is a very good modality for differentiating or knowing about the tumor dimensions and the anatomy and the surrounding lymph nodes. And EUS, they are having a more pickup rate than that of other modalities. So the sensitivity and specificity of EUS for diagnosing cholangiocarcinoma, especially distal cholangiocarcinoma, is around 90% and 85%. So one thing to remember, if you're planning for an LT as a treatment for patient with cholangiocarcinoma, EUS guided FNA is often discouraged to prevent the spillage of the tumor. Regarding pre-operative tissue diagnosis of cholangiocarcinoma, as earlier cited in articles, since cholangiocarcinoma is a post-cellular cancer with sometimes the cellular materials will be low, many times we will end up in situations where the biopsy may not give us any idea about malignancy. So often preoperative diagnosis, tissue diagnosis is not often available for cholangiocarcinoma. So this is one interesting study conducted in Pune by Dr. Matthew Pradeep and et al. So in this study, they were comparing between EUS FNA versus ERCP brush cytology for tissue diagnosis of suspected malignant CVD strictures. So what they found is that there were about 77 patients with CVD stricture, and of which 64 were biopsy confirmed cases of malignancy. So they compared between ERCP brush cytology and EUS FNB. What they found was EUS FNB was having more sensitivity and specificity than that of ERCP brush cytology. The sensitivity of ERCP brush cytology for a cholangiocarcinoma is only 65%, while in case of EUS FNB was around 90%. So this is the conclusion slide regarding the investigation modalities. If you take into, based on the references I have cited, these are the references that I have cited from Indian articles. CCT, the sensitivity is very less. CT PET, as told, it can be very low as 20% to 85%. And MRI MRCP can be 38 to 90%. And ERCP brush cytology 65%. US FNA 90%. So is cytological confirmation always needed for cholangiocarcinoma? So if a positive histology is not always required for cholangiocarcinoma, if the radiological findings are unequivocally proving that it can be cholangiocarcinoma, and you can go ahead with the surgical management if you are confident with the radiological imaging. So where the role of cytology comes is, if you are planning for a neoadjuvant chemotherapy only, the role of cytology is important in case of cholangiocarcinoma. So the treatment of cholangiocarcinoma, always the treatment of cholangiocarcinoma, the cure treatment is surgery. So regarding the surgical option for patients with primary sclerosing cholangitis, liver transplantation is the choice because they will have underlying fibrosis going on if you do segmentectomy. Regarding IHCC, segmentectomy is preferred treatment. If you feel that only lower volume of the remaining liver will be remnant after doing the segmentectomy, we go ahead with ipsilateral lobe embolization prior to the surgery so that there is hypertrophy of the opposite lobe. So regarding perihilar cholangiocarcinoma, either neoadjuvant chemotherapy followed by liver transplantation can be done, or segmental resection with hepatogeniostomy can be done. Regarding distal cholangiocarcinoma, the treatment of choice is pancreatoduodenectomy with lymphadenectomy. So these references are from Indian journals in Gangaram Hospital and Tata Memorials. So regarding the outcome of the study, the outcome of surgery, this is based on the study conducted in Gangaram Hospital. So the outcome, if you look, liver transplantation has an 5-year overall outcome of around 36 to 75%, while the mortality is also high with liver transplantation. The long-term outcome, this is very small study with 30 members done in Kolkata Medical College, where they found that 1 year survival following different surgical options were around 72.7%. So these are the features of patients who cannot be operated. Cannot be operated can be a multi-segmental disease or a bilateral or multifocal disease, portal vein of one lobe and a hepatic artery of the other lobe, or proper hepatic artery involvement, main portal vein involvement, or METs other. Such patients cannot be operated. So, in this study, in the major study that I cited initially from Tata, which had more than 720 patients, what was found is that among the patients who was taken up for, considered for treatment in intrahepatic cholangiocarcinoma, only around 27 patients could undergo surgical intervention. Same case of perihylar cholangiocarcinoma. Even though initially many patients were considered for the surgical options, only few percent, less than 50% patients were taken up for the surgery. The reason is that either the imaging modality after final evaluation were found not surgically compatible, or METs was there, or functional status of the patients were low. So this is a large study which was conducted in Tata Hospital, which showed that many patients who were diagnosed with cholangiocarcinoma comes to us at a very late stage. So most of the patient, surgery is not an option that we can offer either because of advanced stage or poor outcome. So most of the patient, the intervention is in our hands in the medical gastro side and the oncology side. So the oncology side, it is chemotherapy. So regarding the chemotherapy, this is study conducted which showed that the commonest regime used for chemotherapy was gemcitabine cisplatin regime, and this is a North Indian study showed that the commonest regime for advanced cholangiocarcinoma was gemcitabine combination with carboplatin. So the outcome, the 27-month follow-up showed that the progression of disease in these patients was around 87% in spite of getting chemotherapy, and the average disease progression-free survival was only around 7.5 months. That means advanced cholangiocarcinoma, the outcome in Indian studies was found to be very poor. And in gemcitabine carboplatin study group also, the outcome was only around 5.3 months in spite of getting chemotherapy in advanced cholangiocarcinoma. So this is a study conducted in Madras Medical College in the oncology department with a retrospective study of around 30 patients, which too showed that the median survival was around 9 months only for the patients, where they used gemcitabine cisplatin. So the conclusion about chemotherapy studies is that chemotherapy in advanced cholangiocarcinoma, the median survival rate is around 5 months to 9 months. And the hematological side effects were the most common side effects in cisplatin or gemcitabine group. Most common extra hematological side effect was fatigue based on the studies. So, not surgical intervention procedure. This is the role where a role of a gastroenterologist comes into. It can either be due to for relieving the obstructive jaundice. The options can be an ERCP guided biliary stenting or US guided biliary drainage (PTBD) or intraluminal palliation. These are upcoming new modalities. So, in the study conducted in MMC, they showed that either CBD stenting or percutaneous drainage (PTBD) was done in almost 30% of the patients who were inoperable. And in another study, in the large study, it showed that the intervention for biliary drainage was required for almost 79% patients with perihylar cholangiocarcinoma and 7.2% patients with intrahepatic cholangiocarcinoma. And in that study, the large study, the percutaneous drainage was the most common used. So, Dr. Divya Ethal from PGI Chandigarh in 2020-22 concluded that surgery is the only curative treatment for cholangiocarcinoma. But biliary drainage procedures were a cornerstone for treatment of cholangiocarcinoma. There is something known as intraluminal brachytherapy. That too can be considered as a palliative treatment option for cholangiocarcinoma patients. So regarding PTBD, PTBD is a palliative option for draining the jaundice of the patient either pre-operatively or inoperable patients. So in cases where there is atrophy of the liver or atrophy of the lobe of the liver, prior to the PTBD, it is always advised to do a volumetric analysis to decide which lobe to be decompressed. So in this study conducted by Dr. Nikita Verma in PGI, it showed that indication for PTBD in patients, the most common indication for PTBD over ERCP was an ERCP failure or a post-ERCP cholangitis. So these were the indications cited in her study where patients were opted for PTBD and not for an ERCP. Either an ERCP failure or a post-ERCP cholangitis were the reasons. So metallic stents or plastic stents, which is better? It is always for malignancy, metallic stents are better and self-expandable stents are better, because only disadvantage is that if there is a tumor growth into the stent, re-intervention will be challenging for such patients. Regarding PTBD guided bilobar stents, it can be used, Y-shaped or T-shaped stents can be used, or parallel stenting can be used. Now, PTBD versus ERCP, what is the choice? So, concluding based on the studies, ERCP is the safer and less tumor seeding rates when compared to PTBD. But in cases where if ERCP fails, do an urgent PTBD to avoid cholangitis. In hilar masses, endoscopic biliary drainage, that is ERCP, needs more expertise. In lower bile tract involvement, PTBD is not a choice, ERCP is a choice. Then comes our newer hero in the society, that is the EUS guided biliary drainage. So EUS guided biliary drainage can be used, is suitable for cholangiocarcinoma patients if they are not feasible for transpapillary drainage. That means if they are not feasible for an ERCP guided drainage. So the reasons would be advanced malignant hilar biliary obstructions, or surgically altered anatomy where ERCP is difficult, or where there is a duodenal stenosis where we cannot negotiate into a D2, or prior duodenal stents is already kept, or after initial transpapillary drainage. In such situation, we have only two options, either PTBD or EUS biliary drainage. So advantage of EUS over PTBD is that it is having reduction in patient discomfort will be lower when compared to PTBD. EUS is actually more comfortable to the patients post procedure. The internal drainage is always better than an external drainage to reduce the tumor seedling rates. Then can be used to drain any side of the biliary tract, and non-communicating system we can use a bridging stent methods. So I'll be just showing based on the studies which are the different types of EUS guided techniques which were used. So EUS guided hepaticogastrostomy can be done. So hepaticogastrostomy, where the left system can be opened into the stomach, where if there is a obstruction beyond the confluence. Then EUS guided hepaticoduodenostomy can be done if there is a involvement of the confluence, the right system, if it is dilated, it can be opened into the duodenum, that is EUS guided hepaticoduodenostomy. Or if there is a lesion in the confluence, what we can, other option what we can do is we can keep a bridging stent between this. Sorry. So if there is an involvement of the confluence, either option what we can do is EUS guided bridging stent we can keep, plus an hepaticogastrostomy can be done. There is something known as CERES, that is combined ERCP plus EUS. This is done when a patient is having a confluence involvement, and ERCP can be done to keep a, normally as we keep a stent, plus the left system can be opened into the stomach. So what does the Society of Gastroendoscopy of India 2023 guideline recommends about EUS? So this is a recommendation of EUS biliary drainage by the SG Society in 2023. PTBD has a very high interventional complications and poor quality of life. Society of Gastro recommends that both EUS biliary drainage and ERCP as a first line option for patients with malignant biliary obstruction. EUSBD was associated with significant less re-intervention rates, and EUSBD done in patients with resectable malignant biliary obstruction has not been reported to have any of the complications during the surgery of the patient. Currently, EUS biliary drainage is preferred over PTBD as a rescue option in distal malignant obstruction after failure of ERCP, provided we have an expertise for an EUS biliary drainage. This is a take-home message regarding the intervention. So, first of all, if you are planning for an intervention for a malignant obstruction, we have to see if the papilla is accessible or not. If it is accessible, ERCP is the option. If it is not accessible, if the D2 is not accessible, we have two options, either PTBD or EUS guided biliary drainage. So, always as the guideline tells, EUS guided biliary drainage is the preferred intervention. So, we have to check if it is a communicating hilar block. Communicating hilar block means if it is a communicating hilar block, hepaticogastrostomy can be done, or hepaticoduodenostomy. In case of right obstruction, in left hepaticogastrostomy can be done. or if it is a non-communicating, as I showed in the image, a bridging stent can be kept in the confluence, plus a left can be opened into the hepaticogastrostomy or right can be opened into the hepaticoduodenostomy. So this is something new in the line, that is intraductal therapies beyond stenting. We talked about surgical management, chemotherapy, our gastroenterology role, and this is something very new, that is intraductal therapy. So this is this is an article meta-analysis in AIG by Dr. Nageshwar Reddy sir, who tells that endoscopic palliation for advanced cholangiocarcinoma is beyond our stenting procedures. There are two more advanced procedures are there. One is photodynamic therapy, second is radiofrequency ablation. In photodynamic therapy, by using an US1 and ERCP, we enter into the ductal system after photosensitizing the patient, and we give diode laser for destroying the cancer cells and releasing the obstruction of the patient. And otherwise, another option is radiofrequency ablation, that is also an endoscopic procedure. So the studies showed that RFA was simple, but the outcome of photodynamic therapy was better. So this is another endoscopic therapy. So luminal radiotherapy can be done. So classically, the problem with cholangiocarcinoma is keeping the tracers for radiotherapy is difficult. So patients who are having a SEMS in situ, the SEMS can be used as a tracer. SEMS can be used for tracking the tracer, and along the SOIAS we can keep a tracer, and targeted radiotherapy can be done for these patients. So this is one study from PGA, and this is another study from
Sorry,
Dr.
Sanu, you are crossing the time. Another 1 or 2 minutes I think will be given.
So thank you, ma'am. So this comes to the end of my presentation regarding Indian journals. Perihilar cholangiocarcinoma is the most common. Abdominal pain and jaundice was most common clinical feature. Adenocarcinoma is the most common. Bilirubin level more than 8.4 and CA99 more than 100 should prompt us in a case of malignant obstruction regarding cholangiocarcinoma. PET is not a useful tool in cholangiocarcinoma. MRI and MRCP is a useful tool in distal cholangiocarcinoma. Positive histology is not always needed. We can come to a conclusion based on other modalities too. Treatment of cure is surgery. Most patients with cholangiocarcinoma comes to us in an inoperable stage. There comes the role of drainage of obstructive jaundice or an intraluminal chemotherapy. EUS guided biliary drainage is always better than that of PTBD in ERCP failed cases. Thank you. And these are my references.
Cholangioskop in diagnosis?
Cholangioscopic biopsy, spyglass biopsy can be taken, ma'am. But
when it is advised?
In distal cholangiocarcinoma suspected malignancies, ma'am.
Are you really a first year DNP student? Because the way you spoke, it looked like a professor talking with so much authority and fluency. You may good presented, you have covered rightly. Just two questions. One of the pre-malignant conditions, primary sclerosing cholangitis. Yes. So what is the incidence? How many PSCs were there in your series? That's one. Second thing is intrahepatic parasitosis a pre-malignant condition for cholangiocarcinoma?
Regarding, sorry, I missed some of the slides that were removed due to the activity of the time. As sir told, the primary biliary sclerosis was a risk factor, and more than 40% patients had malignant transformation. But Indian studies on that is very less available. There are Western studies on that. Regarding the second question, worm infestation is one of the polylithiasis, worm infestation, long-term polydoccolithiasis. There are literature documented risk factors for cholangiocarcinoma. But in Indian journal, I couldn't find that. But in Western journals, it's available, sir. One issue with cholangiocarcinoma is studies from Indian studies are actually limited. Either case series is other, big number studies are actually limited for cholangiocarcinoma in Indian studies. Thank you, sir.
Thank you, Chairperson. I think thank you so much for taking us through this postgraduate session. I think now, since he said that we have very limited literature, I think probably that should be another part of a project for the Tamil Nadu IST, where we can probably set up a registry and include all patients with cholangio CA. That is probably something that we should think over. Now,
slide கொடுத்துருக்கோம்.
Thank you. This is the brief secretary report for this month. Last month we had a very nice academic feast in the Tamil Nadu Isgtnc that conducted on 10th and 11th of February. Congratulate and thanks all the organizing committees. We had more than about 350 participants who took part in the our state annual conference, and we had quite a good amount of academic activity also, where the postgraduates also presented. We had a variety of prizes presented. We had two orations, Professor N. Madanagopal oration given by Professor Thai Marvin, Professor V. Balasubramaniam oration by Dr. T. S. Chandrasekhar. Both were very well received, and we had a Rising Star Award awarded to Dr. Alvin James, and award prize for the best outgoing student, the DM outgoing student from Tamil Nadu Indian Medical University, to Dr. Kripal. And we had best publication awards, as well as endoscopy video contests, posters, plenary and quiz. So the happy part of this is that there was very good representation from postgraduates across Tamil Nadu. It was not located to one center. It was from the west, north, east and the south, and was part of Tamil Nadu. I think that was very nice to see. And we also conducted the third ECME this month from 9th of March, hosted by Tirunelveli Medical College and Professor Kandasamy and his team. About 70 participants took part in this ECME. I hope to see more postgraduates take part. I think this is mainly aimed at postgraduates who are, it's educational content for the postgraduates, mainly focused on people who are out of Chennai to give them a platform to present. But I think I would encourage all the postgraduates to log in and take part in this presentation as well. And we had a guest lecture also by Professor Thai Marvin. And Dr. Sumati has been taking forward the school education program. She ran one the last month also at a government school, where she's been able to provide awareness about healthy lifestyle, diet, and the lifestyle related issues. And I think hopefully, as part of our society this year, probably will request more members to probably take this forward. I'll take opinion from you how to take this forward. I think apart from academics, I think now the society is now mature enough where we have to take care, we have to go back to the community and see how we can help people around. The Plex study is still ongoing. I think there is some data which has been requested from the last 2 weeks of this month to upload onto the TNSD website. Pretty simple questions: number of cases of ALF, ACLF and severe acute hepatitis, number of liver transplant in the last two weeks of this month, and the number of Plex which has been done. So please upload it onto the website to participate. Upcoming events will be the Endocon, which is coming up in the third week of April. Midterm ISD will be conducted somewhere in August or September 2024. It will be in Tirunelveli. TNSDCon is in Coimbatore in the third week of 2024, and PSG will be conducting this. And please do scan and upload your attendance, so it will be easy for us to take it forward. And thank you so much for my time. I will request to move forward to the CME. I will request Chairpersons Dr. Lognathan, Senior Consultant at the Apollo Hospitals at Vanagaram, and Dr. Jeshwan from the Professor and HOD at Stanley Medical College Surgical Gastroenterology to take it forward, please.
Good evening to all of you. I think we have very big dynamic leaders in now subsequently, and to lead them all, Dr. Malati Satisai is here. I have always loved to hear from her, and she always comes with a lot of newer information. We all know that that is the gateway to good health, and she will talk about it. Thank you.
Good evening. It's not easy to talk after the set of those PGs and wonderful talk they gave. And as you grow older, you lose your confidence also. whether you will be able to talk so well and give all the data which they gave. And the topic also, food as medicine. And there's food waiting behind. The smell of food has already come here, and to talk about food as medicine is also not very easy. Thank you, doctor, for that nice introduction. And this food as medicine, I always used to tell, my mother used to say, சாப்பாட மருந்து மாதிரி சாப்பிடாத, சாப்பாட மருந்து மாதிரி சாப்பிடாத. That means we were making a face or something like that. But this is not what Hippocrates meant when he said, let food be thy medicine. He told it in 400 BC. He meant whenever you take food, that food should be so nutritious, it should be good for your health. That is what he meant. Not like you make a face and மருந்து போல சாப்பாட சாப்பிடாத. It's not like that. And he also added, let food be thy medicine and let medicine be thy food. Long back he's given that. And I think this first half of the title was what attracted me more. And in 1903, Thomas Edison said, he predicted what we are speaking now. That is, he said, the doctor of the future will no longer treat the human frame with drugs. No more drugs, but rather will cure and prevent disease with nutrition. Long back he said that. And I feel all that we have to do is go backward in our development. If we start eating unprocessed food, if we start eating fruits and vegetables, if we start eating rice which was all pounded by the hand, IBD will disappear. IBD came with westernization. Now we have to go back to our rural life. And then I think it will disappear. That is what will happen, that what probably will be the lesson today we will learn. And we had two very popular or very big people who gave the same statement. Ratan Tata, now he is 86 years old. He says, eat your food as your medicine. The same concept. Otherwise, you have to eat medicines as your food. Steve Jobs also said that, but he's no longer with us. So I think this concept is changing, that you eat food not because of the taste, you eat food not because of the nice smell or the way it's presented, but whether it is good for your intestine, it's good for your microbiota, where it's a world inside your body, and that is what is it. So why is it related to IBD? How is it today that we are going to talk about IBD and diet? We all know IBD, the etiopathogenesis, it's not very easy, it is still so complex. It's just the interplay of genetic susceptibility, an immune dysregulation, and then you have an altered environment. The altered environment can be within, it can be without, and this within, this concept of this intestine, there's a change in the environment. There the diet plays. There probably this is the place where we feel that is the thing which is now becoming bigger, and therefore this part, because the diet will be the one which is probably we can alter. We cannot change the gene much. We cannot change immune regulation. The medicines which we are using, that day I was discussing with Dr. Arul Prakash, some terms we cannot even say. It might sound like food. Vidoa, vadaya, what is that? Ustikinumab, upumitinumab, upma, everything. But all that is so complex, and still we don't get good results. So best is to go back to the food. And that is how this diet is now becoming more important, and how this diet is playing in the intestine two ways. Probably it will work on the microbiota, and therefore it causes some change in the dysbiosis if there's a change in your diet. The metabolites of your diet can change that. There's a virulence, pathogenicity is altered because of the emulsifiers, what is added, the additives which are added, they can all change, and I will be talking about a little bit. And then the mucosal adhesion molecules are also changed. It can also act on the immune mechanism. All the protective layers sometimes are lost. The mucus layer is gone. The intestinal permeability increases because of some food. The intracellular bacterial clearance is gone. And all this is the cause for this IBD. We did not have IBD long back. Dr. Raghuram is shaking his head. Yes, I remember we had a meeting, and Dr. Mathan got up and said, I have seen one Crohn's disease. And then Dr. from Mumbai, he got up and said, I have seen one Crohn's. And then Dr. Madhanu Gopal said, I have seen. And then they said, I think all of us have seen the same patient. That's what they said. Remember?
Both cases are going around India.
That's what they said.
Crohn's.
That is what. And I was doing my PG. Antya.
Antya sir, Crohn's visited India, but he is not brought Crohn's to India.
But now I think all of you are treating, seeing, and you don't know what to do, and then it is going round and round and round. So now it's not like that. So now we all know, we used to give this multidisciplinary approach for the management of Crohn's, yes, but now I put that in bold, the font I've increased for the nutritionists because they are now going to play a big role and we cannot talk about diet without them. So now today, the nutritional therapy for IBD, this is a very nice paper. Okay, now we are talking about nutrition, diet, because we don't know what to do. So we are talking about that. We have realized we cannot play much with all those new drugs. It's too much. Every day we are getting more of the complications we are seeing. This was an impact of the dietary beliefs and practices of IBD in India. It was an observational study from AIMS, and they found that nearly 44% of this questionnaire, they perceived food as a risk factor. They thought, yes, it is a risk factor. Inflammatory bowel disease, patients themselves think it is a risk factor. 52% felt that it is more important role than medicines. 77% just reported, yes, they do have some relief when they change the food. So it is like that. So dietary therapy in IBD, you can look at it in 4 areas. One is, we all know, identify and correct the nutritional gaps and the dietary imbalances. So first is, we all know there will be malnutrition, and then this is the most important, can we use it as a treatment during active disease? 3, during complications will the diet change? And 4, can you use diet in the prevention of IBD for high risk patients, for siblings, or you think they may be having? That is the one which we have to consider in the first 4. So the first is identifying nutritional gaps. We all know this. Malnutrition is a part of IBD. It is there. It is very common. And in children it's more. Sometimes we see growth failure occurring even before the colonic symptoms. And this is a concept even in the adults. It will be there. And most of them have shown that the BMI is decreased and that the incidence of malnutrition was 5.5 times higher than those without IBD. So it is there. That overall prevalence, everyone agrees to that. But this is a new concept. Overnutrition has also been reported in IBD, especially in places where there is an increase in obesity. So it's just not that always they will come malnourished. 15 to 40% of adults with IBD had obesity and 20 to 40% had overweight, and they also need treatment. We all know that nutritional deficiencies are very common, and all of us, when we see a patient of IBD, in pediatrics we make a note, is there malnutrition, no malnutrition? So we also have to make a note, and all our prescriptions should have something relating to the diet. Just not the medicines. Diet, you have to talk to them, you have to write it down. Just like we say when you treat diarrhea, write that. It's a prescription. It's just not talking. Talk to them about that. And sarcopenia is higher, reduced skeletal mass, and osteoporosis and osteopenia is more than in the general population. It is there. It is there. So how do you assess? We all know how to assess malnutrition. The Global Leadership Initiative just uses 3 phenotypes. Significant weight loss, if they are able to say if there's low BMI and reduced muscle mass, and if you have reduced food consumption. So we all know why you get malnutrition. One is poor intake, there's anorexia, the medicines, the restrictive diet. We also tell them don't take this. Increased nutrient malabsorption is there is loss, and there is increased metabolism. So everything causes malnutrition. And why are we so worried about malnutrition is when there is malnutrition, the quality of life goes. Whatever treatment you give, the patient does not come out of it. The wound healing gets delayed, ulcers late healing, and quality of life is gone, and then the hospitalization duration is increased. And more than that, biologicals don't respond when your albumin is low. So nutrition is very, very important, and you have to identify it, treat it. Otherwise, they will come to the hospital more frequently, and all that you give will not be there. So you have to identify, and there is a nice paper which has come March 2024, the American College of Gastroenterology, the practice guidelines. They have come with nice 12 guidelines for the best practice advice, and I think it's very, very nice. Please go and read it. And they have given that we have to do screening and that we have to monitor the micronutrients. So usually we do serum albumin because that is still available, and I think it is very important to have some surrogate marker, and we use albumin as that, though the AGA guidelines say that albumin may not be recommended for identification and diagnosis of malnutrition. Yes, it's not for malnutrition. You have to do the other tests. You have to do your CBC, you have to do your ferritin, you have to do the iron deficiency, vitamin D, do everything, and you ensure that they get their proteins. In pediatrics, it's easier. We always calculate the calories the patient requires. We calculate the proteins the patient requires. We calculate the deficit of protein. We calculate the caloric deficit. And that concept, I think, for IBD, we should also ask the dietitians to calculate it and give it to us. Otherwise, they'll say, but how much are they taking? Is it adequate for them? Because it's a hypermetabolic state, IBD, and therefore you should ensure, and the best way to increase the calories, not by increasing the volume, is to add probably little oil on that idli. Add a little oil, then you get your calories more. They cannot eat more than that. So that's how you should ensure that they get their calories. So the main common micronutrient I want the PGs also to remember, apart from just the nutrition, look at the micronutrients. Iron, very, very important. It will be low in majority, nearly 60% of children and nearly 40 to 45% of adults. Vitamin B12, especially if there's an ileal disease or if there's been a resection of more than 30 centimeters, or if you have a ileoanal pouch. Vitamin D, these three, be very, very clear that you have made a note of it, because 30 to 40% have vitamin D deficiency. Now a new concept that it plays another role. It's just not giving vitamin D. It plays a role in immune homeostasis and also in controlling chronic inflammation. Also zinc, folate, calcium and magnesium. Look at these, try to analyze the values. See your prescription contains not only the management, but I always tell them, this you have to take. You have to take folic acid, you have to take calcium, you have to take iron, you have to take, this keeps on going throughout your IBD course. Don't give a prescription without these. They must have that. During the active phase, they may not be able to tolerate oral iron. Now the IV iron is definitely much safer, it's easier to give, you can give it in your outpatient. Pick it up, especially when it's less than 10. Dr. Raghuram is now smiling because he might have seen a case with a problem. I think others also we have seen, but it will not be as the one which we had earlier. Earlier we were so scared of giving IV iron. Now it's definitely more easier to give the iron. So the nutritional assessment, as I was telling you, it should be complete. We'll not go into this because of lack of time, but ensure that your nutrition thing is complete. And then is the most important thing here. Can you use diet to treat active disease? There are 4 groups in this. One is the elimination of certain foods. That's one way of doing it. The other one is the modification of foods such as the FODMAP. FODMAP has been used extensively for IBS, the fermentable oligosaccharides, disaccharides, monosaccharides and polyols restricted diet. I will tell you how it is useful in IBD. In IBD, they have, even 30% can have FGID along with that. So they can have, when the disease is quiescent, they'll come to you with bloat, they'll come to you with abdominal pain, and you're wondering whether it is part of the disease, and we try to push the medicine. But you find all the other parameters are okay. The fecal calprotectin is normal, the CRP is normal. Then you should think whether it is an FGID, and their FODMAP may help to some extent. Then we have enteral nutrition and parenteral nutrition. The elimination diets have really come up in a very big way. We have the CDED, or this Crohn's disease exclusion diet. This is a very unique diet, but it's very helpful. It's a nice paper has come. What you should do is exclude all processed foods, beverages, red meat, dairy products, fried items, and they've found a very good thing. And how will you get the calories? You give 25 to 50% of it with either a enteral nutrition. You give a drink. And that drink, you need not make it as hydrolyzed formula. It need not be amino acid based formula, because that will be costly and it will not be tasty. You can use a polymeric formula. So that is how you will get your calories. So calculate the calories. 50% you give it as that, because you know then the compliance is definitely better. This was a very nice study done in children where they compared it to exclusive enteral nutrition, and they gave the CDED, but PEN means partial enteral nutrition, and they found both the remission rate was the same as exclusive enteral nutrition, but compliance was definitely better. If you give the child or an adolescent the food which is made at home along with partial enteral nutrition, then your remission is also good and the compliance is also good. This is CDED. Then it would be another diet is called as the CD treat. CD treat is more personalized. CD treat you again exclude during active disease. We should remember to exclude gluten. Don't give the milk protein. These two have been proved to be avoided during the active disease. So in this CDED, they have only excluded those anti-inflammatory diet, it's called. Give anti-inflammatory diet and then give a nice menu for the child, improve the calories, and here also they found a very good remission. So the other diets are specific carbohydrate diet, semi-vegetarian diet, paleo autoimmune diet, anti-inflammatory diet, low fat, but all this, there are so many diets, what does that tell you? Nothing has come out and nothing is staying. You have to individualize, you have to tailor, you have to look at the age of the person, you have to find out from where they are coming, what type of food they are used to it, and along with your nutritionist, you must plan a diet for them. Enteral nutrition, exclusive enteral nutrition, and it should be PEN, partial enteral nutrition has definitely helped in remission of the disease. And we had pediatrics also, we find this very good. Enteral nutrition, we all know it is given through the oral. You can use it as a tube, you can place it in the jejunum, you can place it beyond, or exclusive enteral, you can use a polymeric formula as I told you, but you can take it orally or through tube. Partial enteral nutrition will be you combine it with the diet, but that diet should contain anti-inflammatory products. You should not give them everything that they eat. Avoid as far as possible what we should, I'll tell you. So EN is now recommended to induce remission in mild, moderate Crohn's disease in children. And how EN works, earlier we thought exclusive enteral nutrition gives only calories. It's not that. It changes the microbiota. It changes the antigen presenting the lumen. It changes the flora. It changes the permeability also. It changes the interleukins form. And that concept, once we start understanding, we realize exclusive enteral nutrition is a medication. It's just not the calories. It is doing some good job over there. It is doing a job and therefore you should give that. And this is how we say mild, moderate Crohn's, start exclusive enteral. Exclusive enteral means all the calories will be given only by that. You cannot give anything else. 2 weeks you give that and they have said the response is as high as 73%. If the person is able to continue, child is able to continue, you give for 6 to 8 weeks. The same thing, the same percentage has not been reproduced in adults, but still there is a group which recommends, and this recent AGA guidelines also want all adult IBD patients with Crohn's to be started on exclusive enteral nutrition as far as possible. Try it for 2 weeks. If they respond, you continue to 6 weeks. Definitely it will be less problematic, infections are not going to be there and the response will be less. This is a paper from Asian Pacific for, especially for India, they say, where TB is epidemic and you're so scared of biologics, exclusive enteral nutrition is definitely going to help those people. And this is another paper. Therefore, the AGA guidelines are very clear. They say, use exclusive enteral nutrition for even adults with Crohn's disease. And the best practice advice also says, if you can, you use partial enteral nutrition and then you do exclusive enteral nutrition, especially preoperative. I think for the surgeons, they would like that. You get your calories and you feel that everything will be well and it's all digested. This is a very nice paper. I think this paper only stimulated Ramanagan to ask me to talk on this. Using coconut water as an anti-inflammatory in ulcerative colitis along with the standard treatment, it showed a good response. So they gave it for 8 weeks. So I think this is a nice learning for us also. If we can use coconut water, and there's one slide which is missing here, that this is from him, Jaswant. They've also showed that our rice kanji, our fermented rice, has been useful for the colonocytes. So what are we doing? We are going back. Yalanira kudi, arsi kanji saapdu. And you can treat, you can do something for the colonocytes. It's a very nice paper which has come recently and I think you were part of that research. which has shown that how it works on that. So what about parental nutrition? Earlier everyone used to just put a needle, shove it there and give parental nutrition. Yes, we have very good 3-in-1 bags. We have calories which you can give up to 2000. You don't have to worry much about it, but realize most of them have to go into a central line, especially when the hyperosmolarity is higher. You can't use the peripheral line and infections may be higher. But definitely it plays a role when there is intestinal failure, when they just can't manage the calcs with anything else, when they have failed and patient has insufficient bowel function to maintain nutrition and high output fistula. Especially in high output fistula, this will work. So in the complications of IBD, will dietary management work? I'll just tell you a few things, especially intestinal fistula, you have to use only parental nutrition. For those with strictures, don't give high fiber food, don't give that, see that they get very soft food, see that they get only the enteral nutrition which I was talking to you about. So these are the places where you have to go, as long as far as possible, try to convert PN to EN as far as possible, and the best practice advice, they have also said the same thing. So this is very, very important that you have to change it quickly, and so for all the complications, you must give food. Just few more, I was just telling you about the non-inflammatory complication which we don't think about in IBD. We always think only about the complications. Non-inflammatory complications like FGID is more common. And there if you FODMAP, yes, in IBS it is useful. Here you may compromise the nutrition. So you have to do a little bit of juggling here. There may be lactose intolerance, then you decrease. There may be a proximal constipation. You're always concerned, how does this ulcerative colitis get constipation? When only the distal, then you have to give some amount of fiber and you may have to give a softener. Now I have one patient saying here, Madam, frank bleeding, distal colitis. But why is the frank bleeding? Passing hard stool. So you know, how are we going to manage this? You may have to change the diet pattern and give that also. The final is the prevention. How did this thought come? Because Western diet, they found IBD was so prevalent in the West, in the developed countries. The developing countries did not have it. Then the developing countries becoming transitional. We started not only Western style of diet, our dress, that did not cause IBD, but then our diet changed. And therefore, you know, whatever that, their diet in Western diet, whether it's the protein, whether it's their fat, whether it's their carbs, whether it's their beverages, the size, the amount they take, it all caused it. The emulsifiers, the coloring agents they used, that was the reason this got. And therefore, it's a nice paper which you can read again in Indian Journal of Gastroenterology, where there are definite protective factors for IBD where if you use, especially breast milk. Then Sumati is here. If you give exclusive breast milk for 6 months, you can definitely decrease IBD. If you give for 12 months, not exclusive, but at least continue, it is very good. That is the one which is thing. And then vegetables, fruits. Vegetables also, very clearly they have come to cruciferous fruit. I put a picture because definitely I knew Raghuram will ask, what is that cruciferous you're writing? So I put that because cauliflower, broccoli, cabbage, all that is that. It's not like, they don't talk about brinjal, yam. So these are the fruits which contain high anti-inflammatory property, and try to give food which contains omega-3 fatty acid. So what will be, which you will know, walnut probably is very good, and then you can again use these cabbage and other things. And Anantha Krishnan has shown in a nice study, doctor who came and spoke to us, that if you increase the fiber only from fruit, he's made a talk, you can reduce the incidence of Crohn's disease by 40% in his study. So just imagine. So finally, what would you like to advise them as a preventive? Low fat, high fiber, fruits and vegetables if you eat. So all of us, we become more vegetarians, but that's not the answer because we need little protein also. And potential triggers will be high carb, too much of sweetened drinks, too much of the emulsifiers if you have. If you eat red meat, I think that is very, very important. Avoid that. Pork, strongest evidence is for sulfur and the butyrates, which will be the risk. So how do you prevent? I told you earlier, ultra processed foods should be avoided. So what is ultra processed? So we were once using the unprocessed food, nothing we did to them and we just ate it. Then slowly only the additives were added, and that is known as the group 2, where only the culinary ingredients are there. Then little bit of processing came and we had that. But now the amount of ultra processed food, this is the one which is causing a lot of harm and increasing. If we can stop this, if we can go to schools and tell them that they should stop having all this pizzas, ice creams, all the deep fried food, that is the cause for inflammatory bowel disease. So our change should be there, and this will be the summarizing. So the take home messages would be nutritional therapy plays a very vital and major role in the management of IBD in all the 4 areas. Yes, in malnutrition it plays a role, in the active disease it plays a role, it plays a role in the complication, it plays a role also in the prevention. Exclusive enteral nutrition is recommended in mild, moderate CD. Special diets are available. So if we start taking low fat, good fiber, fruits and vegetables, unprocessed food, it would be like saying the way backward, go backward, but actually you will go forward in decreasing the rising incidence of IBD. Sorry, I took some time, and thank you for your patient listening.
I appreciate, ma'am. It was a very good presentation and a lot of things to learn. I'm happy that Spark is also next to me here.
Yes.
I think a lot of us will have a lot of interactions, but paucity of time. We will have 2 questions and 1 contribution from the audience, and we will have 3 minutes for our just one.
Yes, his paper.
No, I just want to say comments only. I believe in one statement, though it is not substantiated. You mentioned about westernization. The main culprit is the refrigeration. The moment we started refrigerating food, the incidence of IBD, especially Crohn's, has gone up. In olden days, our mother used to cook everyday food. We didn't have a refrigerator, and this was less. And the second thing is, however much you advise, our patients, they have both phobias and obsessions. You may say so many things, they'll accept your drugs, but once you talk about diet, they'll say, I'll consult my party and then take it. So this will have to...
And the party ஒழுங்கா தான் சொல்லுது சார் நம்ம because அது நல்ல காய் இல்ல சாப்பிடலாம்.
Just one question. See, I can understand the food playing a role in the small intestinal disease, but how does food help the colonic disease of ulcerative colitis? Does the food reach there? Does it? What is
so the food mainly, like especially the fiber, which they say it breaks down into short chain fatty acids, produces butyrate, and the butyrates are very important for the colonocytes. So definitely there is there, and the same thing, that is why only in UC the omega-3 fatty acids works, and the same concept of the butyrates and that coming and working on the colon and acting on the colonocytes. The colonocytes are changing, and the gut flora also changes, so the colonocytes help. But the most of the, what you said is the studies have been done for Crohn's only. For the UC, only that one study where they have shown it's more important. So I think that coconut water for UC is another nice paper, and I thought that was very nice. We can always also ask our patients, especially ulcerative colitis, along with that. Yes, Arun Prakash, you're shaking. Good, no, that was a nice paper. I think Arun, he saw that paper only and put this topic. Very nice. 8 weeks you give 400 ml of coconut water twice a thing, in a whole day 400 ml, and they had so much of changes. They've calculated the activity index, and they've also examined the flora, and they said the flora had changed. Very good.
I didn't have any question, but since you tracked my name, right, I retired 27 years back, and I'm not as aggressive as in my olden days when I used to teach you, right? That's a different thing. But thing is, I think my pediatric classmate always says milk is a poison. And now when I'm thinking back, white revolution came around 60s in America. So they had higher incidence in 70s, 80s, like that. Now our white revolution, so-called this packet milk, has come in 70s. And we are now from 90s we are facing the problem. Crohn's.
This cow's milk protein, as I think there was a concept, especially in children with IBD, they said those who had CMP are more prone for IBD, but in adults this did not work out. So they have said at present don't stop cow's milk unless it's during active disease.
Where is the cow's milk now?
It's all.
Where is the cow's milk? There's no cow's milk.
Finally, the protein is the same, no lactoalbumin, globulin, that's how it is. The protein is the same, but it's all a source is the cow's milk protein source.
So what my classmate used to say is, if there is no milk for the mother, give coconut milk and or give this milk. So I was thinking that that concept taken over. This white revolution came in 60s, and all these inflammatory bowel diseases are occurring in 80s in America. Now our white revolution came in 70s, and now by 90s we are seeing plenty of cases. Is there any relationship to milk other than the fast foods? That I agree with your concept.
Yeah. Milk, the milk is only for children, where they've said this, because we are also seeing cow's milk protein allergy more than what we saw earlier. We are seeing
What
that.
is the cow's milk at
That
all?
is
I don't
because
think
the
we talk about
whole
cow's milk.
environment has changed. It is a milk protein, sir. Whatever you call it, it's called as a food protein enterocolitis. The source is, it's the same milk protein. It is either lactalbumin or lactoglobulin, that is all.
Consider
Whether it's a camel or a buffalo or whatever it is. It's anything else?
Yes, sir. Can I request?
Yeah.
Just one to comment.
Yeah, we can ask more from you actually. My concept of food, let the food be thy medicine. That's the concept. Everything started, I come from village background. By doing MCA, I only started getting the ulcerative colitis, Crohn's. We never used to have that. Especially parties, they are only permitted to, only fermented rice water. Never used to have any disease, and they used to die of only voltage, 80s, 90s, 100. They never had this much calories, this much protein, all these vitamins, all those things. So it will be hard working people. That is how it started. I used to ask for all the history, food history, everything, all the people like that. People used to take fermented rice water, all fermented food. They never used to have all these diseases. That is how everything started, and started treating ulcerative colitis from 2010 onwards. So referred for the surgery. After 2010, I have not done any surgery for plain ulcerative colitis. I have done only surgery for malignancy developing the ulcerative colitis. That is how it started. Now we started treatment for Crohn's, ulcerative colitis. Crohn's, it gives immediate relief of symptoms. Very next they will tell, okay, taking fermented rice water and give this relief and all. Basic concept, exclude the diet which precipitates the symptoms and advise them fermented rice water. That's how everything started. When patient comes initially to me without any treatment or any chronic diseases, they all get well with only fermented rice water. Fermented rice from rice water alone. And we did study also in the fermented rice water, we study the metabolites. It contains more than 1,800 metabolites. We are able to characterize only the around 150 metabolites only. That contains everything.
The postbiotics you call it.
Yeah, postbiotics. All antioxidants, more than 30 antioxidants, more than 15 anti-inflammatory agents, and more than 15 anti-cancer agents, and antimicrobial agents also. That's all more than 10. And neuroprotective cardiac, all these are there only. That's how they get instant relief also. That is how they get the relief in the ulcerative colitis also. So single most important factor, more in my experience, than any other medicine, collectively together, it controls many diseases, IBS, IBD, GRD, everything actually. It is very good for infertility also. That is how I convince the people. If you don't take it, you will be infertile. See the infertility clinics and all. That agree. Another thing is regarding protein. In Papua New Guinea, they take only 10 milligram per kilogram body weight of proteins. Still they are muscular and all is very good. How it happens is we don't have urease in our body. In colonocyte, the urease producing bacteria enters the colonocyte and split the urine and send the nitrogen back, recycling. That is how they maintain the protein. Actually, there is no need for that much proteins. Proteins are pro-inflammatory than cancer-causing agents. We take so much proteins, that's the thing. So there are so many things. And gut bacteria also manage the hormones, especially estrogen and all. Then comes the infertility and all those things, PCOD and all the things which comes here. There's so much to diet and all. Thank you, madam.
Thank you. I think the gut microbiota is changing.
I think before I conclude this, there is a request from me, personal, and I think most of us have joined in this. I think one of our members is the Vice Chancellor, and probably we can start some fellowship courses on nutrition and liver disorders and IBD. I don't know, I think it's for the secretary and president to decide about it. And go ahead. Thank you.
Thank you, sir.
Only food, there is no need for medicine, there is no need for surgery also.
Thank you, Isgtnc, for having invited me to speak today on this subject. I see quite a familiar faces here, teachers, colleagues. Most remarkable is Professor Raghuram, whom I see that he looks the same, what I saw him about 20-30 years back. So thank you. And the topic given to me is Rise of Phoenix. Something, Phoenix, I think, who has used this word, I don't know. So, Phoenix is actually a bird, probably was seen at Arabian Peninsula, which survived for 5 to 6 decades. And then after his death, life came from the ashes. And so that means it is immortal. It is. So that's the use. But here the phoenix is that what is emerging data. That's what I feel. So I will just take a few minutes to go into the latest vision or what is the current literature which says the role of early surgery in Crohn's disease. My topic is that. So let's recap first. Crohn's disease is a chronic idiopathic multisystem disorder challenging clinical entity both medically and surgically, inflammatory, fibrostenotic and fistulizing. About 70 to 90% of these patients ultimately require surgery. When you go into the key history of the Crohn's disease, I think it was called long back as regional ileitis. If you remember, you would have read those things. But in 1933, only the first paper, the Crohn, it was updated as Crohn's disease. A notable landmark is that the president of the US, Eisenhower, actually, he undergoes the intestinal bypass somewhere in 1956. So then subsequently so many things have come into vogue, the Montreal classification, all those things. I don't want to go into the details. So my topic today is benefits of early surgery versus biologicals. As we know, for the past 2 decades, biologicals are chosen as a frontline treatment as compared to the conservative therapy which was being given. So there are a lot of emerging literature, a lot of probably some presentations and discussions would have taken in this forum before regarding the biological. I remember once Dr. Bhatt has spoken extensively about that. But as relates to the early surgery, let us discuss, here it says steroids, mesalamines and all those things. Ultimately from biological it jumps to surgery. So when you look into this pyramid, the mild antibiotics, aminosalicylate, moderate steroids, severe we use the biologicals, and then goes to surgery. That's called bottoms-up treatment. Now the future is the top-down therapy. That is, now the pyramid is reversed here. You see here, from early they start the biologicals, and when you see this pyramid actually, the surgery goes from down to the up, going beyond the other treatment modalities, and that takes the front seat, especially in an early Crohn's disease of the ileum and ileocecal region. We'll discuss in future about that. So it is the objective of my presentation is to formulate a decision analysis model based on the recently published data to explore whether early surgery in Crohn's disease is preferred over biological treatment. So it is, of course, treatment is closely an interaction of the multidisciplinary team consists of gastroenterologists, surgeons, psychiatrists and nutritionists, so on and so forth. Now, what are the 3 W's of Crohn's surgery actually? Let's go into that. Why is surgery recommended? Complications and non-compliance with medical therapy, incompatibility with lifestyle, steroid dependency,
intolerability to other medications. When surgery, when there is bowel obstruction from stricture, intra-abdominal abscess, as presented by Dr. Shankar recently, fistulae, free perforation, phlegmons, and cancer of small bowel and colon. Then what will you do here? Ileocolic resection for the ileocecal or distal ileal disease. Approximately 87% of patients with ileocecal disease eventually require resection. So why? Because laparoscopy for Crohn's disease is an appropriate setting and is feasible and safe. It is an emerging data actually, with fewer wound complications, less tissue trauma, shortened hospital course, and early resumption of oral intake, etc. Now, if you look into the recommendations which have come recently, the American College of Gastroenterology says the recommendations is surgery is reserved as a last resort. You see here. They say it is only for complications following the Crohn's disease. Whereas if you go into other three, the guidelines, the next one is the British National Institute, that is the NICE study, says surgery is recommended as the earliest stage of the disease as a therapeutic alternative to medical therapy. Similarly, the German Society of Gastroenterology and the German Society of Visceral Surgery, European Surgery of Crohn's Colitis Association, they also come out with a similar data that surgery is recommended as an early option. So, early surgical therapy in Crohn's disease is characterized by, why you want to? So, it is characterized by low morbidity and mortality. Because there are several newer advances in the surgical techniques of minimally invasive surgery which has come into work, like laparoscopic, robotic, and since fast-track eras, etc., which has simplified the surgery and patients' morbidity and the stay, comfort, and so many things have come down as compared to the open surgery. So it is a kind of a recluse for these patients who suffer from this disease. Now let's go into the studies. This is a Danish study in which they have studied for about, from 15 years they have studied the analysis in the cohort. So they have studied as two arms. One is ileocecal resection, another is the anti-TNF treatment. So if you see the first the graph, 33% lower risk of long-term adverse outcomes found with the ileocolic resection. Whereas we go to the anti-TNF treatment, 50% of the ileocolic resection group on no treatment for at least 5 years. This is another trial, the CONNECT trial from Korea. What they say? They say early surgery group was defined as patients who underwent bowel resection within 1 month prior to the or after the diagnosis. That's what they define as what is early disease. It is 1 month prior to or after the diagnosis of CD. What is late surgery? It is a group which is included in patients who underwent surgery during the course of disease or at least 1 month after the diagnosis. That is a late surgery. So duration from the onset of symptoms to surgery was shorter. That is, limited length of disease was in the gastro. That is, what do you say is the shorter limited length. Limited length is less than 40 centimeters. That is said to be from ileum to ileocolic region. That is called as the limited length. Larger length they have defined as more than 100 centimeters. But then there is a gap which they are not able to explain. So, the duration of symptoms to surgery was, onset of symptoms to surgery was longer. So, less use of biologics in the early surgery, whereas more use of biologics in the late group, actually, they found when they compared both the groups. So, in the early group, better post-operative clinical outcomes. In the late group, clinical outcomes lesser than the earlier surgery group. In the early group, less cumulative bowel damage. What is this cumulative bowel damage, you may ask me? They say there is a study in which they found that the patient may be taking the treatment, steroid therapy, immunomodulators, miscellaneous. But in spite of taking the treatment, the patient may be having a cumulative bowel damage. It doesn't mean the patient is undergoing a kind of cure or relief. There is a cumulative bowel damage with your ongoing medications. So that leads to subclinical inflammation and disease progression, which continues during the clinical remission of the Crohn's disease. So more the cumulative in the late group study, in the late group they say more cumulative bowel damage due to longer duration of the disease. There are other studies also which recommend, Italian study. Initial diagnosis of CD during surgery was associated with lower risk of reoperations and less use of steroids and immunosuppressions compared to the CD diagnosed clinically and initially managed with medical management. The Hungarian study says early limited resective surgery was associated with a lower risk of reoperation and overall exposure to, with the lower risk of reoperation, overall exposure to steroids and the biologics. There is one very landmark study which was published again from Netherlands, where it's called Lyric trial, in which they have taken a cohort of 143 patients, and what they say, if you see that on this weighing machine down to the left, that is what is the pros of medicine? Pros is advantages of medicines. The Dr. Piramagam may say, you may argue that medical treatment can be a less invasive and reversible. It is gut sparing, disease modifying. Whereas disadvantage of surgery, you may say that it is invasive and there is a loss of gut. You are losing the gut. And post-operative complications and recurrence. And then the patient has a big wound and there is a loss of osmosis. But what the surgeon say here, see onto the right side. The advantages or pros of surgery is more definitive surgery, quicker symptom relief, cure in some cases, disadvantage of medicine or cons of medicines, contraindications, the escalating costs, adverse side effects, risk of dysplasia, effect on operative morbidities. So these are the things that has been discussed by the medical management and the surgical people. So when you see this particular graph with the median follow-up of, in this group they have followed up for 5 years. So in the 5 years study they found 74% of the patients who initially had an ileocecal resection did not need additional biological treatment. You have to mark it out. 74%. Whereas 42% did not need any additional treatment of disease flares and none required a second resection. So that is the advantage of early surgery. Conversely, 48% of the patients in the infliximab group had a Crohn's disease related resection, while other 52% either maintained anti-TNF therapy or their drug therapy was switched or escalated. So what does it mean? These findings further support laparoscopic ileocecal resection as a treatment option in patients with Crohn's disease with limited, what do you mean by limited? Affected segment of less than 40 centimeters and predominantly inflammatory terminal ileitis for whom conventional treatment is not successful. So, if you look into this chart, there are two things, pie charts that's called. These two pie charts. So again, this pie chart says whether there is a need for anti-TNF therapy and surgery in each. So let's go into the details. In the resection group, 26% of the patients, you can see my arrow here, 26% of 69 patients did not need any additional Crohn's disease medication, whereas in the infliximab group, here my arrow is here, onto the right side, the blue one, patients in the resection group were less likely to need, that is, I'm sorry, in the resection group, in the second comes, they're less likely to need an infliximab treatment than the patients in the infliximab need a resection, sorry. So, in the resection group, all patients who required additional treatment was due to disease flare and clinical symptoms alone. Whereas in the infliximab group, patients required additional treatment not only for the disease flare, but due to intolerance of the infliximab. So, the incidence of additional treatment was 18.6% per person in a year in the resection group, compared to 20.8% per person in a year in an infliximab group. So, this is what they say in this particular medication and versus surgery. Now let's go into the economic evaluation of these clinical trials. If you look into the chart, again they have taken two arms. On the left, laparoscopic ileocecal resection, onto the right is the infliximab group. Number 73 and 70. It is divided into index treatment and readmissions and reintervention, second one. So let's go to the index treatment, ileocecal resection. So the median cost is about, it is in euros they have mentioned, that is 4,240 euros. 1 euro is equal to 80 rupees, you can calculate. So around 3.5 lakhs roughly. So similarly, when you come to this medical groups, that costs when you come to the infliximab group, come to the second line, the total cost comes to around 14,197 euros. That is almost, it is 3 times, more than 3 times the cost escalation. So when you come to the subtotal, in a resection group, the total cost is about 9,074 euros. So 7.5 lakhs. Whereas if you come to the subtotal of the infliximab group, it comes to around 17,000, about 18,000 euros. It comes to at least about 20 lakhs it comes. So imagine the amount of the money that they are spending, where they can just, as compared to the early resection. That's what I want to say here. So, what is known and what is new and what is future? What is known, with the failure of conventional therapy, treatment is intensified with biologics. That is what we are doing now. Infliximab treatment is associated with considerable economic burden on the society. Whether you will agree here or not, I don't know, because you are the experts. What is new? Lap ileocholic resection is associated with significantly the lower total cause disease related direct healthcare costs and compared with the infliximab treatment. Hence, ileocecal resection is a valid alternative to infliximab induction. What is the future? Given the improved quality of life and reduced total societal costs after 1 year, LAP ICR should be considered as a valid alternative to infliximab therapy in eligible patients with cause. I am using the word eligible very carefully because I will be, there are people who are going to shoot me actually. I am in the form of gastroenterologist. So, what is the updated clinical trial says? The luminal ileocholic Crohn's disease, we do MR enterography, again divided uncomplicated and complicated. So onto your left, uncomplicated. Uncomplicated, a multidisciplinary team discusses. There are several approaches, step up, top down approach. And then after that they go to surgery here. I have put a dotted arrow, you will see that. Whereas in a complicated disease, after exhaustion of all the medical treatment, patient goes into complications, he is referred to the surgeon ultimately to go on to the surgery. Now it's out of question for you to treat. But then, here, you see these broken arrows. What does it mean? That, why do you want to treat with medication, biologicals or whatever it is, at the early stage? Refer to the surgeon. Understand? So, அதாவது தமிழில் ஒரு பழமொழி சொல்லுவாங்க, தும்பி விட்டுட்டு வாழையாக பிடிக்கிற ஒரு மாடு கூப்பிட்டு போகிற Tubbi uttu vaal puchadu oditharku. That is, go, catch the tubbi, surgery. Purida? So Ravi is looking at a different angle. So, now let's come to the last slide. The patient comes with a Crohn's. The gastroenterologist scratches his head as to what to do in a limited disease. See, then surgeon says, yes, I'm here, good. I'll take care of the laparoscopic ileocecal resection. That is what the great surgeon from Cleveland said. Go for the surgery when it is recommended. Don't delay and get proper medical treatment after surgery. With appropriate care from both colorectal surgeon and gastroenterologist, people can essentially return to normal quality of life, where they can do whatever they want. That is said by Dr. Ruggiero from Cleveland Clinic, US. So that's what I conclude here with my talk. But I want to ask my dear colleague, who my work, ஒரு நல்ல குடலா கேஸ் வச்சு அனுபவம் என் கேஸ் நெரிஞ்சு போன குடலை கொடுத்தா நான் எப்படி ஆப்ரேட் பண்ணுவேன்? நல்ல குடலா கூட நெரிஞ்சு போய் அது காம்ப்ளிகேஷன் வச்சு இந்த ஆப்ரேட் பண்ணுன்னா அதில் எவ்வளோ காம்ப்ளிகேஷன்ஸ் வரும் அது புரியுதா? ஸோ நல்ல குடலா கொடுங்க இனிமேல். நெரிஞ்ச குடலா கொடுங்க. I realize your support, yeah.
Thank you, sir. Nice talk. Talk about the preeminence of surgery and its role in Crohn's disease. Unfortunately, there is no comparison with the dietary therapy.
What?
Diet therapy. Kanji. See, I got 2 patients with endocrine fistula abandoned by physicians or surgeons, just controlled with
Why did you publish that?
This is coming.
See, this is an emerging trial from Europe actually, and this is actually, there are several discussions and for the past 2 decades this has emerged, and we ourselves, I myself was surprised when I came to know, because most of the time we operate Crohn's disease only after the complications. I have done cases, structuroplasty, resection, then fistulizing Crohn's disease, enterocutaneous fistula. I think that Dr. Kannan is there to witness all those things he might have seen. And perineal Crohn's disease, that we are not talking here. That is either isolated or in combination with Crohn's also I have seen. So, it's the incidence is rising actually, because as Madam has said, Malati has said that the food habits are changing. There's civilization, the activities, everything is changing. So we are we are getting all the things from the Western countries, all these Crohn's, IBDF, etc. We are now able to see here itself. So we have a lot of things here. A museum of all the, you can say, of Crohn's disease and IBDs. So where we have to have our own Indian study and publish our spectrum of the diseases, as you said, that multicentric trial can be put, because there are a lot of cases around, and that's how we can do it.
I think it's open to the audience here.
Yeah.
So are you saying that if you do an early surgery,
What?
if we refer a patient very early, are you saying it is curative?
Definitely, you have read this here. I already showed in my slide. See,
even when we medically treat them early in the disease, they remain symptom free and they get a very good remission. It cannot be curative, They have to be on drug even after surgery.
No, I am comparing this with the biologicals and ICR. I am not comparing
biological also.
Yeah.
If we start biological very early in the disease, they will have equally
very good. There is a good study. You just see the studies. There are 2 arms they have published, and I want to tell you also, it is
a limited.
Yeah, that's what I have used. I have used the word cautiously. A limited disease, less than 40 centimeters. I have not said 40.
So you also said if you operate 1 month before diagnosis, how is it 1 month before?
That's the Italian study here. You see?
So he said 1 month.
Yes, please.
That early surgery, I agree with you, for idiopsychical growth.
Yeah.
But not for other growths.
No, I'm not telling you.
Don't make a generalized statement.
I'm not making. A terminal, no, what they say, a terminal ileal and a terminal ileal and ileocolic limited to 40 centimeters, in which there is only a limited inflammation without any stenosing lesion. Like it should be a limited disease of 40 centimeters, terminal ileum and the ileocolic limited to 40 centimeters without any complications.
I think that's very important that the phenotype has to be mentioned again. It is only the terminal ileum and that part, not anywhere else.
That's correct. I agree with you. I agree with you. That's
and
what
the
is.
other one is, I think, that inflammatory stenosis it should have gone into the fibrosing type.
You are
because
correct.
only when it's inflammatory for the biologic work.
Yeah.
So you're pouring biological into a lesion where it's not going to work. That is the part you have to take it for the surgery. Because unless there is inflammation, the biologicals are not going to work. So I think what you're saying, but we have to stress that importance.
No, but the
That
study,
is why
madam.
correct what you're saying.
Madam.
I'm actually citing you.
Madam, see the study. See the study here. You see the study.
Yes, I'm also telling your thing only.
Yeah.
I'm saying that.
I'm not talking from my side. The studies is talking.
We'll be pouring money into a drain where it's not going to work. So best is to resect and
That's correct.
that is it.
That's I support you. Correct. I support you.
Can I make a comment?
Yeah, please.
I can be corrected if I am wrong. I
Okay,
think
sir.
the
Yes, sir.
understanding quite recently,
Please,
the
please.
list of ACG is also similar
Yeah, yeah.
on similar lines.
Yeah.
But as Dr. Ravi said, it is not curative. So it doesn't prevent any other disease occurring in the later years in a patient.
No, that's right. You are correct. I do. Yes.
That's number one point. Number two is like what they have said is, these patients do not require medications for some longer time than the conventional medical treatment. And their quality of life is slightly better. It looks like if it is a focal eosical disease, then probably surgery may be an option, and it is emerging universally. But it does not prevent the occurrence of growth.
You are
in other
correct.
areas.
I strongly agree. That's what they say. Only that particular, when they compared that particular early surgery resection group and infixement group, only that particular early surgery, they found that early surgery was advantageous as compared to the biologicals.
I am referring to your cost comparison slides. See, now you are comparing the medical cost with infliximab, which is a very highly costly drug and has to be given parenterally. Nowadays, we have orally acting biologicals which are quite effective and which are much cheaper. So maybe that cost comparison must be modified in reference to orally available biologicals.
I think there has been a bigger argument right from the time of my college studies on DM. See, we had a very sick patient with ulcerative colitis, and his cost of treatment, everything was going high and high and high. And my professor asked the surgeon, can you please operate and remove the entire bone? I think they said, no, it's not ethical. You complete the medical treatment, and then if there is a complication, then we go for that. I think that answer to that question still remains, because your ulcerative colitis surgery, you give a cure. Right? Instead of continuing with the medications, which are quite costly, and doing so many things for understanding the complications that has come out of it, and like then only when the cancer comes, you will operate on it. It's $1 million question. I don't have an answer till now. Actually, I think I can expect some guidelines from the podium also.
This is emerging data. Emerging. Yeah. Want to ask something?
No.
That's all.
You're not in late, yeah.
Shall I go?
Yes, sir.
Thank you.
Keep on going. Thank you very much.
May I request Dr. G. Ramkumar, Superintendent and Professor from DDST, to enlighten us on managing infections during the treatment of IBD.
Yeah. Sir.
I thank the Tamil Nadu ASG and my friend Dr. Pirama for inviting me for giving this lecture. It gives me immense pleasure to stand before my teachers who taught me gastroenterology. I asked Pirama, what's the time duration? I said, I hope it's 30 minutes. He said, no, it's from 8 to 8:30. So there's a lot of difference between 30 minutes and 8 to 8:30. I will try to finish before 8:30. The topic is managing infections during treatment of IBD. I'll be discussing three scenarios. Reactivation of latent infections like the tuberculosis, CMV, varicella, herpes simplex, or a concomitant acute intestinal infection, or the rapid evolution of chronic infections due to loss of immunological control like the hepatitis B, C and HIV. The first two will be two case scenarios which I met, and I'll be happy if some of the PGs could answer or raise their hands for the questions. The first is patient are diagnosed as ulcerative colitis, mild to moderate, start on tofacitinib 10 mg BD for more than 18 months. After 18 months, this patient developed a strip of blisters on the thorax with very severe pain of acute duration, onset 2 to 3 days. And that's the picture. I hope everybody knows the diagnosis. It's herpes zoster. While treating this patient, I did not know that I should vaccinate the patient before starting before COVID. So what does literature say? Long-term risk of herpes zoster infection in patients with UC receiving Tofa. The incident rate is pretty well stable for 7 to 8 years. More common among the elderly with low BMI and prior TNF inhibitor failure. Preferably, patients receiving more than 10 mg BD are at increased risk than 5 mg BD. But majority, more than 90% of these herpes are mild and non-serious. Most of them resolve without discontinuing Tofa. The drug of choice is oral acyclovir. So how to prevent? So use a live or a recombinant zoster vaccine along with Tofa. The vaccine preferably should be given 2 to 3 weeks before the onset of immunomodulators. But I put the word not in 100% because this herpes zoster is not mild in 100%. About 5% they are serious, and 5% they may need therapy, and in less than 3% the vaccine fails to prevent. So the next case is a 26-year-old male who came to the ER department with an acute abdominal pain, distension, obstipation. Abdominal X-ray shows multiple air fluid levels. The CT confirms a small bowel obstruction. So surgery, emergency laparotomy, intra-op, ileal stricture. So they did a resection and anastomosis. So the biopsy histopathology came as Crohn's disease. So after the wound healing, this patient was started on tapering dose of steroids simultaneously with azathioprine and mesalamine. And this patient was stable for almost 18 months after this episode. But suddenly one day he came to me with a severe perianal pain, not able to sit, swelling, tender, fever. What's the diagnosis and how to proceed? Anybody in the back? Yeah, it's simple. Perianal abscess with a probable fistula and ano. So what next? Either to start an antibiotic or directly do a surgery to continue the immunomodulators or start biologicals. So most of the perianal abscess, 60% perianal, 30% ischiorectal, 5% submucosal or deep pelvirectal above the levator vessel. If the patient has got a tender abscess, I would go for a surgery, incision drainage. So the management of perianal abscess in a known Crohn's disease is surgery to drain the abscess plus or minus ceton placement, antibiotics, immune modulators, azathioprine, methotrexate, biologicals, infliximab, adalimumab, cetuximab, Bido and ustekinumab. There is no role for steroids, aminosalicylates or cyclosporin in the management of perianal abscess and fistulas in Crohn's. So the surgical management, just a small word. sorry if I made some mistake in this slide. First is the surgical drainage of abscess, the set-on placement to prevent premature closure of external orifice along with anti-DNF therapy, the fistulotomy and ligation of intersphincter fistula trap or fistula plug or fibrin glue. So, my patient was diagnosed in the MRI with a perianal abscess fistula. So, he underwent drainage of abscess with control of sepsis. Following after a few months, he developed a fistula. So, I started him on adalimumab. I suggested him infliximab, but he was not favoring for this infusion. So, he took adalimumab for 9 months plus azothioperin almost 125 mg per day till date. 6 months later, starting adalimumab, the fistula completely healed. And adalimumab was stopped 3 months later, that's totally 9 months due to financial reasons. And the patient was asymptomatic for 5 years. Now again, he comes back with a perianal swelling, perianal abscess. So what next? Anybody in the back? Yeah. So, what is the role of anti-TNF therapy in fistulizing Crohn's disease? It is, the meta-analysis says it's very efficacious. Infliximab has proven efficacy in induction, maintenance and remission. In infliximab primary non-responders, ustekinumab is a choice. In infliximab secondary non-responders, either ustekinumab or adalimumab can be tried. But in our case, adalimumab secondary non-responder. So I have suggested him infliximab and we are waiting for the next drug. So the lesson learned from this is I should have pressed for infliximab. Maybe. So what does the systemic review and meta-analysis say on the loss of response? There is an annual loss of response of 10% for infliximab and 13% for adalimumab. So therapeutic drug monitoring may help in the management of Crohn's disease with secondary loss of response to adalimumab. Next is a 40-year-old male known ulcerative colitis on Azeron with a recent history of hospitalization for acute febrile illness or flu-like, for which is treated with paracetamol, analgesics, NSAIDs for severe myalgia, following which he presents with an acute onset of multiple episodes of watery diarrhea. So the differential diagnosis is either Clostridium difficile, CME colitis or parasitic infestations in the endemic area. So let me talk about C. difficile in IBD. It is more common in IBD with colonic involvement. Even Crohn's disease patient on remission with no recent hospitalization or antibiotic exposure may have asymptomatic carriage of toxigenic C. difficile. The risk factor for development of C. difficile infection is NSAID usage, recent hospitalization, emergency room visits, antibiotic usage and biologicals. And patients IBD who have developed concomitant CDI have an increased duration of stay in the hospital, exacerbation of silent disease, and they have a higher risk for colectomy. So, in any IBD patient presenting with new onset diarrhea or worsening diarrhea, think of C. difficile. So, stool testing, the initial testing, I don't think we have this test in Chennai. It's an immunoassay for the Clostridial glutamate dehydrogenase, which says the patient has C. difficile, both toxigenic and non-toxigenic. But the most specific test is the specific C. difficile toxin A and B. So the sigmoidoscopy, which we read the classical picture of a pseudo membrane, is rarely seen in a CMV colitis in an underlying IBD patient. But the sigmoidoscopy helps to identify the extent and the severity of inflammation, and biopsy to rule out CMV colitis or parasitic infestation. So CT is done to rule out perforation and toxic megacolon, and the management is oral, and the patient is sick, IV vancomycin or fludoxomicin. Nowadays, metronidazole is no longer recommended. So next is CMV and IBD. Is cytomegalovirus an active pathogen or an innocent bystander? This is more common in UC than CD because of the T helper 2 type, which down regulates the antiviral cytotoxin, but in Crohn's disease you have T helper 1 which upregulates the antiviral, so the cytomegalovirus infection is less common in Crohn's disease. The risk factors: age more than 30, on immunomodulators, refractory to anti-TNF therapy, steroid dependent, steroid refractory, ulcerative colitis. So symptoms: the patient present with all this bloody diarrhea, urgency, tenesmus, fever. It's very difficult to differentiate between CMV colitis and UC flare. Particularly if the patient is a known patient of ulcerative colitis, we can suspect. If the patient comes to you for the first time with all these symptoms, whether this is simple for initial presentation of ulcerative colitis or a primary CMV colitis with an underlying UC, it's very difficult to differentiate. So, and these are the few questions I would like to. Do you perform a test to detect CMV in new IBD patients? How many of you say B? How many of you say C? B. In new IBD. So, majority, I think they go in favor of C. When do you do diagnostic test to detect CMV colitis in active IBD patients? C. Severe exacerbations. How many of you take this? Okay, few. Corticosteroid refractory exacerbations. 1. Biological refractory exacerbations. So I can see people doing the CMV colitis in last 3, C, D and E. Which endoscopic finding is suggestive for CMV colitis? A, B, C, D, E. How many of you take D? Large punch. Okay. So the description given in the book is large punched out ulcer, longitudinal oval to irregular ulcers, erythema, erosions, mucosal edema, and very rarely pseudotumor-like. And which diagnostic test you do to confirm the CMV colitis? So I saw my friend Bharat raising hand for last 3 sessions, so I think he's got a lot of experience. Sir, which D? PCR and colonic? Yeah. So in the blood, if you go for a positive CMV IgG, it confirms past exposure and identifies the risk. If you have a positive IgM, it detects acute infection or CMV reactivation, but do not correlate with CMV colitis. And suppose you have a CMV antigen in the polymorpholeucocytes, that is also does not, they don't have a upper cutoff value beyond which is confirmed CMV colitis. So the best is histology. The routine biopsy with H&E staining showing the owl cells is pathognomic, high specificity. But if you add immunohistochemistry along with the histology, the specificity increases. But if you do a tissue CMV DNA PCR, which has the highest sensitivity. So patients with symptomatic disease should undergo induction therapy with IV ganciclovir or foscarnet. So particularly steroid refractory and steroid dependent UC should have a colonic biopsy, go for a tissue CMV DNA PCR. If the biopsy shows a high grade CMV density, antiviral therapy is combined with anti-TNF therapy. If there is a low grade therapy, antiviral therapy is given in the case of a large colonic ulcer. And if there is no CMV, increase the immunosuppressant. So next few slides about what are the other infections which I took from the literature. Human papilloma virus and IBD. So a regular gynecological screening for CS cervix is strongly recommended for women with IBD who are on immunologicals, and patients with extensive cutaneous warts and condyloma consider discontinuation of immunomodulators. Current or past HPV infections, there is no contraindication for immunomodulator therapy, and routine prophylaxis with HPV vaccination for women according to the national guidelines. Next is Epstein-Barr virus. Screening for latent or subclinical Epstein-Barr infection is not recommended before starting immunomodulators. If there is a severe EBV infection, start the immunomodulators and start the antiviral. And if the patient presents with an EBV related lymphoma, stop the immunomodulator, which leads to spontaneous regression of lymphoma. Very rarely, patient may go for chemotherapy. Next is JC polyomavirus. So, Crohn's disease patients who are on natalizumab and vedolizumab, if these patients develop any new onset neurological symptom, they should undergo a contrast-enhanced MRI to rule out progressive multifocal leukoencephalopathy. So that's the neurologist problem. But anyway, we must be aware of this PML. Next, influenza virus and IBD. Patients on immunomodulators, high risk for flu. So routine vaccination for all IBD patients on immunomodulators is suggested. Live vaccine not recommended. And the seroconversion after vaccination is not reduced by steroids, methotrexate, anti-TNF therapy, but it is reduced by the thiopurines and the cyclosporids. Tuberculosis and IBD. I'm not going to talk about the diagnosis of Crohn's or TB, just what is the relationship. The anti-TNF therapy increases the risk for tuberculosis. Majority are atypical, 50% extrapulmonary and 25% disseminated tuberculosis. The mortality is 13%. So patients with a latent tuberculosis must receive a full course of ATT. When there is a latent TB and active IBD, anti-TNF therapy must be delayed by 3 weeks after starting ATT, except in the case of a clinical emergency or urgency. So how to prevent? So before planning for therapy, do a chest X-ray, a manto, and the TB quantifier on gold. If active TB is diagnosed, start ATT, stop anti-TNF therapy, and restart anti-TNF therapy after 2 months. Azaron, methotrexate, and steroids need not be discontinued. So next is the hepatitis virus. Hepatitis B flares in HPSAG positive IBDs. Patients receiving infliximab are reported. So prophylactic antivirals are indicated in patients who we are planning to start on infliximab. In HPSAG negative with positive, there is occult HBV. Reactivations can occur following infliximab, but routine antivirals are not indicated in occult HBV. In HCV, anti-TNF therapy, there is no impact on HCV infection, so can be used with concomitant HCV. But if the HCV is acute HCV, it's very rare, less than 10%, anti-TNF therapy can be continued. So last slide is HIV and IBD. The course of IBD was not different among the HIV infected and HIV uninfected patients, and no safety concern regarding treating HIV infected patients with current biologicals used in IBD. So the use of anti-TNF therapy in HIV patients with a CD4 count of more than 200 has a very good, safe, acceptable safety profile, and there is no data on the drug interactions between ART and biologicals. Thank you for patient hearing.
It was a short and sweet presentation. And we have only one question and move forward.
Just an observation. All patients with perianal disease started on biologicals will invariably relapse once you stop the biologicals. This is my experience. So all of them will require long-term biologicals.
Yes, sir.
The problem here is I think they stop themselves because it's healed, there is no more discharge, etc., etc. But they come back after 3 months with an open wound. So I think these sort of patients we need to plan treatment as a teamwork with the surgeons. Probably we need to completely drain the abscess with antibiotics and then probably start them on biologicals. They fare little better if you do it this way. But you put them on biologicals, if they stop, they come back again with the same disease.
Beautiful lecture. I am really thrilled. Only one point for to society. When you treating IBD, insurance problem is there. I think society should address this problem because although cases are not very heavy, but the complications in treatment, lifelong treatment, the society, Tamil Nadu society being already involved in data poisoning, they should take it in a long way and go for free treatment at all the hospitals Thereby, the IBD problem, which is nightmare, can be prevented. Thank you.
Thank you, sir. Point well taken. Certain sort of time. Thank you, Dr. Osman.
Thank you.
Thank you, presenters and professors and dear colleagues. We won't stand between you and the dinner. I thank Sun Pharma and Residency Towers for providing the ambience for the today meeting. We hope we had a good academic feast today. So we'll proceed for dinner without any delay. Thank you. Thank you all.